of amphotericin. He had febrile reaction, thrombophlebitis, nausea, hypokalemia, rise in creatinine. We stopped amphotericin intermittently for 6 to 8 days, and patient was treated with 2.4 grams of mucormycosis treatment with amphotericin. This diagnosis was disseminated mucormycosis. Now, mucormycosis, this last slide. Mucormycosis is seen in immunocompromised patient, diabetes patient. In the COVID era, mucormycosis has played havoc. I have seen in super specialty OPD in GMC, patient with mutilated face, patient with enucleated eyes, uncontrolled diabetes and mucormycosis. This is the COVID infection, steroids, and diabetes becomes a triple hit, and it has caused havoc in diabetic patients. So this patient had disseminated mucormycosis. There are 6 forms, and disseminated mucormycosis can have 50 to 60% mortality, but we could save the patient, we could save the eyes of the patient. Amphotericin, I have already talked. Last slide. Invasive fungal sinusitis can present atypically with severe acute loss of vision with minimal anterior orbital inflammation. This patient had pulmonary lesions in addition to rhinocerebral lesions. So disseminated mucormycosis with 70% mortality. Visual losses does not recover completely, but still this patient was saved and vision was salvaged. So underlying fungal sinusitis is an important differential diagnosis in a case of acute loss of vision in a diabetic patient. Thank you very much.
This uncontrolled diabetes in that patient who required insulin, are there any other cases reported of insulin resistance in childhood?
Sir, if the insulin requirement of any patient goes more than 2 units per kg or more than 200 in an adult, that is a case of insulin resistance. So most of the time they are congenital, they have acanthosis nigricans, Cushing syndrome, acromegaly, steroids patient they develop insulin resistance, disseminated infection, obesity. But this case of insulin resistance was absolutely rare. This is because of insulin antibodies. Another is insulin receptor antibodies. These are immune-mediated insulin resistance cases.
Thank you.
COVID in hospitalized and non-hospitalized patient, any idea?
No, I don't know. This infectious patient will tell you. I don't have. But I have seen huge number in my super specialty OPD. Hospitalized patient I saw there, and they had a havoc. Enucleation of eyes, ethmoidal, maxillary sinus removal, disfigurement of figure, of face was a huge problem during COVID days.
Thank you, sir. Now I request chairpersons to felicitate Dr. Sunil Ambedkar, sir, Dr. Vasnik, sir, and Dr. Rashmi, madam. Please felicitate Dr. Sunil Ambedkar.
Invite next speaker, Dr. Mishram, sir.
Now I request our next speaker, Dr. C.M. Meshram, sir, for his talk on movement disorder.
So the next talk on the movement disorder by none other than Dr. Chandrasekhar Meshram, sir. Sir is the neurophysician and director, Brain and Mind Institute, Nagpur, sir, president of Indian Academy of Neurology, and many more things to his credit. Over to you, sir.
Thank you. Today's topic is movement disorders, and you can see this is a sequence from a song, Natu Natu, from a movie RRR, which received the Oscar award. These are orderly movements, and we are seeing the disorderly movements. Natu is important because in Pali, it is called as I personally saw it. In Pali language, Natu is the meaning of that. So, if you don't see the movement disorder personally, you can't diagnose. By reading in the books, you can't diagnose movement disorders. So this is important. So because this is a very fascinating condition and the diagnosis is clinical. You have two types of movement disorders, akinetic rigid syndrome and hyperkinetic syndrome. Akinetic rigid syndrome, the prototype is Parkinson's disease. Hyperkinetic syndrome is chorea, tremors. These are the common conditions. The Parkinson's disease, the four cardinal features are bradykinesia, resting tremor, rigidity, and impaired postural reflexes. Idiopathic Parkinson's disease, by and large, is almost always unilateral. So if it is bilateral, you should be worried that this is not Parkinson's. And this condition was diagnosed by, or first time described by, a general practitioner in London, James Parkinson. So a general practitioner, if you have got observatory skills, you can diagnose many conditions. And if you want to know about Parkinson's, you should read a book by a neurologist, Oliver Sacks. And on this book or novel, a very interesting movie, Awakenings, which was nominated for Oscar and featuring Robert De Niro and Robin Williams. Robert De Niro acted as a patient of Parkinson's disease. It's a very interesting movie. So what are the clinical features of Parkinson's? And which are the various points you should see when you examine a patient of Parkinson's disease? So this patient has masked faces. You can see that he hardly blinks. So if someone comes with these faces, then you can suspect that you are dealing with a patient of Parkinson's, and you can see this glabular tap is positive. This is another patient, and you see the alternating movements. On the left side, he has got a severe hypokinesia. There is arrest of movements, and the range of movement is less. See this patient, there is a loss of associated movements. Both the hands are almost tied to his body. This is another patient showing rest tremors. When you ask the patient to walk, the tremors are exaggerated. This patient this is a very classical rabbit tremors around the face. So when you see such type of tremors, this is another patient with lingual dyskinesia. So rabbit tremors and dyskinesia are very classical features of drug-induced Parkinson's syndrome. And there are various drugs. Any drug can cause Parkinson's disease. The very commonly used, your domperidone. I have seen patients with domperidone. The commonest is levosulfuride. Any medicine which contains L in the end, and the patient comes with Parkinson's syndrome, you found the culprit and the treatment is very easy. You stop the drug and the patient is better. So levosulfuride is a very common, so don't use levosulfuride. I have seen very commonly people using left, right and center. Acidity is not a problem. It's not a disease. It is a symptom. Your diet is wrong or something is wrong. So don't overtreat acidity. Now, sometimes you may not get the history of that which antipsychotic drug the patient is on. And I had seen a patient, clinically I thought that he has drug-induced Parkinson's, drug-induced syndrome. But patient realized that he is not taking any drugs. I said, ask for homeopathy drug and other drugs, Ayurvedic drugs, which can also cause. He said, no question. Then I asked his wife, he said, no medicine, he's not taking any medicines. But I was quite certain that this patient has a drug-induced problem. So then I sent the patient out and I asked his wife, I said, it's a question of your husband's life and death, and you have to tell me the truth, that what is wrong. Now then she confessed that she has a friend who said, उसने पूछा कि ये तुम्हारे हस्बैंड आजकल बहुत शांत रहते हैं, पहले बहुत चिड़चिड़ करते थे, आपको ये करते थे. हाँ बोले, वो मैं तो उनको कुछ दवा दे रही हूँ. बोले मेरे हस्बैंड का भी वही प्रॉब्लम है, मेरे को दवा दे दो. तो बोले वो खाएंगे नहीं. तो देन शी सेड गॉट एन haloperidol from her friend and she started mixing that haloperidol into the dal. So husband also did not know that he is getting the medicines. So dal fry with haloperidol led to the Parkinson's syndrome. So you should dig out the history of drugs. This is another patient having bilateral symptom with drug-induced Parkinson's. This lady, who initially was treated somewhere as a case of for vertigo with cinnarizine, which is very commonly used, and she developed Parkinson's syndrome. Now, once I was asked to see a patient, I got a call from my friend at 12 o'clock in the night. He said, Dr. Meshram, चलना पड़ता है, पेशेंट ने तो शादी टूट जाएगी. There is some emergent problem. The girl is having a problem and they are about to have those pheras. And I will come to pick you up. He was a doctor. So he said, as a consultant, he said, please come with me for sake at 12 o'clock midnight. I want to see the patient. And when I saw that, I thought it's a drug-induced dyskinesia, nothing serious. But the family was very worried that the girl, the bride, was getting this abnormal movements, dyskinesia, dystonia. So then I asked, is she taking any medicines? She said, no. Then I called her brother. I asked him that कि तुम्हारे बहन की शादी टूट जाएगी, बताओ अभी क्या कुछ मेडिसिन. तो बोले नहीं मेडिसिन कोई नहीं बोला, कुछ तो मेडिसिन ले रही है, तुमको मालूम होना है. So then she pulled out one packet. He said, yes, she is taking medicines to prolong the menses. Now, she was prescribed risperidone and the chemist gave her, she was prescribed regesterone and the chemist gave her risperidone antipsychotic and she landed in a trouble with this. This patient had dystonia because of organophosphate poisoning, the hyperkinetic disorder. This is a very classical patient. I should show because this particular condition, paroxysmal kinesiogenic dystonia, I have got a largest series of about 75 patients in the world. Nobody has seen so many patients in the world as much as I have seen. So these are the clinical features. This is another patient. This is a patient of chorea. Okay, we'll move. Sometimes the video gets hanged and Okay, I think now we should move. Yeah, this is a patient, diabetic patient having hemibalismus. Her blood sugar was 450, non-ketotic hyperglycemia, very classical condition. This is an interesting patient because this is a young patient with extrapyramidal manifestations. And when you see somebody walking like this, then you are certain that you are dealing with a patient of case of Wilson's disease. And you can see this KF ring, very classical because of deposition of copper. And I had one patient who worsened. I was worried why he worsened suddenly on treatment. So it was when there is a chronic problem, they go to Baba. And the Baba said कि रोज तांबे के इसमें सुबह उठ के पानी पीते जाते. And the तांबा has, because in the Wilson's there is a deposition of copper in the brain, that tamba the patient has got deteriorated. I will stop here. Thank you very much.
Now I request chairpersons to felicitate Dr. Meshram sir.
Dr. Demre madam, please join.
We invite next speaker, Dr. Lina Abhire Kalmage.
I invite Dr. Lina Bire Karmak, Madam. She is the renowned obstetrician and gynecologist, consultant obstetrician and gynecologist, IVF specialist since last 21 years. Madam is the expert in managing the high-risk pregnancy and malignancies. So over to you, Madam, for your talk on redefining women health. Need
you
to
so
repaint
much.
the canvas.
For your kind words. And I was held back in my chair by the mesmerizing talk by Dr. Chandrasekhar Mishra. So I'm still yet to be out of it. Anyways, today when Manisha asked me to talk on something on obstetrics and gynecology, and it's a mixed bag with the galaxy of stalwarts, experts in different fields, I thought I should share something not very topic-wise, but what we have inculcated, what we have experienced over a period of time dealing with different patients of obstetrics and gynecology. Now, whenever we talk of women's health, the three most important aspects of women's health is fertility, pregnancy, and cancer prevention. So, conception requires healthy seed and healthy soil. But despite having everything ideal, the chance of having clinical pregnancy in a particular cycle is only 30 to 40%. With the recent advances in diagnostic modalities, it has proved we can detect beta HCG at very low levels. It has proved that this is not merely the failure to conceive. It is preclinical loss of pregnancy that leads to fecundity of 30 to 40%. Not only that, the journey of pregnancy is fraught by many potential complications like spontaneous miscarriages, recurrent miscarriages, preterm births, abortions, loss of fetuses before 20 weeks, sometimes IUGR, PPROM, preterm premature rupture of membranes, eclampsia, preeclampsia, HELP, DIC, accidental hemorrhage, and so on. The last few of them contribute in major towards maternal as well as perinatal mortality. Then only 50% of them approximately, it could be explained on the basis of causes which are attributable. But in 50% of patients, the cause yet remains unexplained. So this generated interest in the immunological aspect of pregnancy. Now you see, pregnancy is allograft. That is, it has 50% genetic material from the patient, the host own, and 50% that is foreign, that is from father. So naturally, the host has to accept this pregnancy and tolerate it for 9 complete months. For that, the maternal immune system needs to be adjusted, modulated, and all the complications of pregnancy, predictable, unpredicted, they are supposed to be now, what we have experienced in the last few years, we can attribute it to the maladaptation of immune system. Now let us see what happens in how immunomodulation takes place in pregnancy. Now one of the recent advances in the field of immunology is delineation of CD4 T helper cells. Now important for us, the obstetrician is Th1 and Th2 system. As we know, Th1 is cytotoxic immunity, it is aggressive, it is responsible for controlling the intracellular infection, and it is responsible for graft rejection also, hypersensitivity, and VT, that is venous thromboembolism. And the diseases governed by this system are multiple sclerosis and rheumatoid arthritis. Now another system is Th2 system, which is humoral, which is and it is milder also. And the diseases governed by this system are SLE. In normal pregnancy, Th1 is suppressed and Th2 is predominant. These two systems act against each other. So now what happens whenever the embryo comes for implantation in the endometrial cavity, it gets attached to the endometrium, what is shown there. Now this attachment at the site of endometrium here will be decided by the immune response at the interface between the endometrium and the embryo. Now, if the maternal host immune response is not adequate, not ready to accept the embryo, if predisposing factors are there to oppose the implantation, then the pregnancy will be rejected at the time of implantation only. So that is what I say, the fate of the pregnancy is sealed at the time of implantation only. Why? Because if now whenever any tissue comes for implantation, it goes through its growth factor. Now, if the immune system of the mother is hostile to this acceptance, it will reject. Or the fate of the pregnancy will be decided at what is the quantum of that opposition. So it may be rejected at the time of implantation, or it may grow for some time. Depending on that severity of maladaptation, the pregnancy may be lost at the implantation, after implantation, with missed abortion of 8 weeks, 10 weeks, or it may continue, because the process of placentation continues till 20 weeks. Even though placenta is formed at 12 weeks, the vessels which supply at the placental bed, they undergo remodeling. And what happens in remodeling is that the serosa and muscularis layer of spiral vessels is eaten up by cytotrophoblast. And that is again decided, the trophoblastic invasion is decided by the maternal immune response. And that has to be Th2 preponderance. If Th1 is dominating, it will not allow proper eating up of the serosa and muscularis, and hence maternal neuronal control on the spiral blood vessels will still be there, and it will go into spasm, and that will be reflected into uterine artery PI, which we do at 11 to 14 weeks of pregnancy. So now what happens in preeclampsia? Preeclampsia is a major contributor towards maternal and fetal perinatal mortality. Now what happens in preeclampsia? Preeclampsia is a syndrome specific to pregnancy associated with variable degree of placental dysfunction and exaggerated maternal inflammatory response. Now what is etiology of preeclampsia? It is the vasculoendothelial injury, dysfunction causing disruption, microthrombi, increased fibrinogen consumption, increased FDP, DIC, and if not recognized in time, it leads to maternal death also. So all these things are governed by Th1 system. And that is why it has now been said, or it is accepted or proved, that the patients who have got preeclampsia, they are more at risk for development of cardiovascular diseases. Again, the reason being vasculopathy. But still, you have 20 to 30% patients of preeclampsia, severe eclampsia, HELLP syndrome, or acute fatty liver of the pregnancy who do not have prior manifestation of classical triad of preeclampsia, what we say in diagnosis, that is appearance of hypertension after 20 weeks, edema, or they have proteinuria. In these patients of around 30%, they come to you as a surprise. And that is what happens when you have a nightmare as an obstetrician, because you have not predicted. It's okay if patient comes with an emergency to you, but if she is your bookcase and she lands up into this kind of a catastrophe, then you are unable to answer why this happened. And this happens because the manifestation may be different. It may not be anything initially. Sometimes they take you by surprise, because anything, any trigger can initiate the maternal inflammatory response. So what does that mean? That means every pregnancy, irrespective of history, is prone for manifesting with complications of immunological maladaptation. What does that mean? That means every patient, whether normal, without history, with history of abnormal fetal outcome, or bad obstetric history, you must consider her as a high risk for development of any untoward complication of pregnancy, unless proved otherwise, till she delivers uneventfully. And that is why you must have some protocol, because we have seen patients who decompensating like this, coming everything normal, then suddenly comes up with accidental hemorrhage or HELP syndrome or unexplained IUGR in later life, because now we have practiced for more than 23 years. In later life, they manifest with either arthritis or SLE or Sjogren's disease or something like that. Means there is some history of immune disorders in those patients which were not evident at the time of their initial pregnancy. So that means you should first take the history of patient. If history is suggestive of bad obstetric history, repeated abortions, IUGR, previous preeclampsia, family history of autoimmune disorders, hypersensitivity, any rash, urticaria, or unexplained IUGR, you must have your antennas high. And then how to prevent this? It is not possible that for all the patients you will advise them to take the investigations for immune disorders. You have a screening pattern, just do their CBC, assess for platelet count. For high-risk patients, or even for normal patients, you do CBC, SGOT, SGPT, LDH, uric acid, and inflammatory markers at the time of 36 weeks, and that is going to give you the idea. Now, the another factor is the most important role of a gynecologist, which they have to deal is cancer cervix. Now, cancer, we know cervical cancer, India contributes 26%, and 83% of the Southeast Asia. And today we say 1 patient dies every 8 minutes in India. The battle yet to be conquered. I just like to highlight few points. We don't go into pathophysiology of cancer cervix. Metaplastic cells are responsible for development of cancer. And if they are exposed to any mutagenic agent, whether it is HPV, HSV, or it is sperm, they are bound to develop into maldevelopment type of growth, which leads to dysplasia, and that is cancer cervix. Now, we say 99.7% cancers are caused by HPV. Now, few questions needs to be answered. If HPV is responsible for cancer cervix, then we have been taught since beginning that Jews and Muslim communities, they have less chance of cancer. Then how come they have immune mechanism to protect their ladies from cancer cervix? And if HPV is epitheliotrophic cancer, then why not glans penis cancer is as common as that of cancer cervix? I would like to draw your attention for few reports so that we can miss the chain which we are missing. This is the patient who has got positive pap smear and LBC for HPV virus. Her colposcopy for high-grade squamous intraepithelial lesion. Her colposcopy shows high-grade lesion, but she is HPV negative. And this is the paper, this is the poster you will see. Here, patient is of cancer cervix, carcinoma in situ detected on biopsy and colposcopy, but her pap smear is negative. So by just focusing, this is her histopath of hysterectomy specimen. So by just focusing on HPV positive patient to be screened further for cancer cervix, are we missing the best bus? And we are depriving the women who really need this screening by just changing the track. We are denying them from screening for cancer cervix. So what I feel is, do we need to repaint the canvas in terms of management of pregnancy and cancer cervix screening? And we need to change our attitude so that we should be able to crush this scenario of cancer cervix and give best to our female patients by providing at least one chance for cytology in life and at least one she should undergo colposcopy in lifetime. Thank you.
Thank you, madam. That was the wonderful talk.
I request chairpersons to felicitate madam. Dr. Dhamre madam, please join. Shankar sir, please join. Thank you, madam. We invite our next speaker, Dr. Suresh Chavre sir, for his talk.
Dr. Suresh Chavre sir is the MCH Plastic Surgery, MS General Surgery. Sir is the plastic, cosmetic, vascular, microvascular, hair transplant surgeon. He is he did his fellowship from the Tata Cancer Center, Mumbai, and from the cosmetic surgery and plastic surgery from the APSI. And he received many awards. The important one being they received patent for design of the temporomandibular joint in 2020. So over to you, sir.
Thank you. Respected chairpersons, seniors and my colleague. At the outset, I say congratulations to Team Baho, Trishila Dembre Madam, Shankar Khobragade sir, and whole hard-working team for organizing such a wonderful organization and giving platform to all of us. Respected sirs, very good evening and Jabim to all. Today I am presenting vascularized lymph node transfer for lymphedema, hope for cure. When you see these kinds of limb, what thought come to your mind? You may say, what hell is this? Yes, lymphedema is a chronic debilitating, disfiguring and incapacitating condition that results due to disruption of lymphatic transport system. There is no fully satisfactory treatment for the lymphedema. Many patients receive inadequate treatment or unaware that treatment is available or do not know where to seek help. In this disappointing world of lymphedema, vascularized lymph node transfer is a ray of hope. I am presenting series of 9 cases operated since 2009 to 2023. 4 females and 5 male, age ranges from 37 years to 72 years, and in all cases diagnosis was lymphedema grade 3 and 4. 2 patients presented with the cellulitis and lymphoria. 1 patient had history of oncological pelvic exenteration with radiotherapy. In 8 cases, diagnosis was presumed to be filariasis. Though as filariasis is more common in our India, and follow-up was from 3 months to 3 years. In all cases, thorough clinical examination was done to rule out any comorbid conditions and to have the physical fitness for the surgery. Limb circumferences was consistently measured in all cases as a reference point. In all cases, diagnosis was confirmed with a lymphoscintigram scan, and a color Doppler study was compulsory done in all cases to rule out venous or arterial causes. In all cases, I have advised preoperative treatment in the form of a compression bandage, skin care, application of emollient to prevent the cracks and secondary infections, and presuming it is a filariasis, diethyl carbamazine 100 milligram 3 times a day for 6 weeks was given in all cases. This is a surgical management. What I have done, I have transferred vascularized lymph nodes from the left axilla in all cases to the leg, and these are implanted in the calf. You can see this is the harvested vascular flap, and the medial artery is exposed in the mid calf. And you can see this is a microvascular anastomosis, and this is spinal insetting. This is small video. You can see I am doing the marking in this to harvest the axillary lymph nodes. When we do a harvesting of axillary lymph nodes, we have to prevent the harvesting of the sentinel lymph node to prevent the lymphedema of the upper limb. The flap harvest is in progress, and this is a harvested flap before detachment. You can see I am detaching the flap with a vascular pedicle. It is based on the thoracodorsal pedicle, thoracodorsal artery and vein. And post-operatively, I gave POP slap for almost 15 days. Bed bearing started after 3 weeks. Stitches were removed on 15 days, and compression bandage applied after 3 weeks, and they have to apply for a lifelong. Results started, the improvement was seen from the first week itself. There was a significant decrease in edema with normalization of skin and cosmetic appearance in all cases except one. There was improvement in mobility and day-to-day activity, increased social involvement and interactions. Overall quality of life was improved in all patients, and there were no episodes of the cellulitis and infection. Hematoma occurred in one patient, and wound disruption was a decision seen in 2 cases. These are the only complications seen in 9 cases. These are the few cases I am present. This is my first case. 50-year male patients having the lymphedema of 6-year duration. Skin condition was normal. This is a pre-operative pictures. After giving the conservative management, you can see a little bit decrease in edema. And this is a lymphoscan, shows the dermal backflow, confirmation that diagnosis is a type 3 lymphedema. I did chest X-ray to CT chest to know the presence of the lymph node in lateral chest wall. And you can see the improvement after 6 months. This is a pre-operative, and after 6 months, there is absolutely normalization of the skin without any secondary procedure or excision. And the results after 12 months, after 24 months, and after 3 years, the results are still maintained with the compressions and normal contour of limb and the normalization of the skin. These are the various measurements which shows that there is a significant decrease in the edema. This is a case of the grade 3 lymphedema of around 8-year-old. She had multiple episodes of cellulitis and lymphoria. And this is a lymphoscan conferring type 3, grade 3 lymphedema. You can see the results after 2 months. After 6-7 months, almost 90% reduction in the volume. And after 15 months, the results are well maintained with the normalization of the skin. This is a case 3 with the grade 3 lymphedema. And this is preoperative pictures. After 3 years, you can see there is a significant reduction in the limb volume with the normalization of skin. She is able to wear normal chappal. This is an extreme case when he presented with me with the complaints of the lymphoria and severe cellulitis. I gave the conservative treatment to him. He was having lymphedema about 25 years duration. And this is after conservative treatment in the form of antibiotic, moisturization, limb elevation, crepe bandage. And when I did surgery, you can see the results after 3 weeks, 3 months. And after 1 year, results are maintained. This is an extreme case of the lymphedema after 40-year long standing with repeated episodes of lymphoria. He came to me only to treat the lymphoria. I did lymph node transfer in this patient, and you can see after 7 months there is a significant reduction, and he is happy that there is no lymphoria at all, though there is not a much reduction in the volume, but he is happy. And this is a case of the pelvic extension with radiotherapy for the CS cervix, having the lymphedema of a 20-year duration. And this is after conservative treatment. And after lymph node transfer, you can see significant reduction in the volume with the normalization of skin without any secondary procedure. Results are maintained after 1 year. This is a grade 3 edema, lymphedema operated in December. Sorry. And these are the results. I am not satisfied with the results, but there is a definite improvement. This is this patient operated in January, grade 3, severe edema with secondary changes in the skin. And you can see after 6 weeks, almost 90% reduction in the volume. With the there is a shrinkage of the skin, and this skin definitely will normalize over the period. This is this patient operated 3 weeks back, extreme lymphedema with the various complications. And you can see within 2 weeks there are improvements. Size started decreasing, and you can see wrinkles in the skin. Here there is a complete collapsed these nodules, completely collapsed nodules, and over the period definitely there will be improvement. But this patient may require some secondary procedures. So lymphedema is a chronic progressive disease that affects a significant number of the people and have deleterious effect on the physical and psychological well-being of the patient. Goal of the treatment should be decrease in the limb firmness, swelling and volume, decrease cellulitis and infection rate, decrease quality of life, eliminating the need for the compression garment, minimal donor site morbidity, and improve appearance of the recipient site. Hence, we planned vascularized lymph node transfer from the left axilla to calf. It is a more physiological procedure and had potential for cure of the disease. Lymph node transfer works, how they work. The mechanism, it is act as a sump, and there is a neo lymphatic generations. The indications of recurrent infection, extreme fibrosis, and even elephantiasis and persistent pain and resistance to physical therapy, conservative therapy. This is a world literature review. Corinne Becker is a pioneer in this lymph node transfer, and she reported 40% improvement in upper limb and 33% in lower limb. But in our series, it is almost 85.71% decrease. Complications may be upper limb edema, which can be prevented by the reverse mapping. And absolute contraindications are venous insufficiency and obesity. In conclusion, vascularized lymph node transfer is a very useful technique to treat lymphedema, and it has potential for cure for the lymphedema. Thank you very much. Thanks.
Thank you, sir. Now we request chairpersons to felicitate Dr. Suresh Chowre, sir.
I would like to request Dr. Rajesh Ramtake from the audience to felicitate Dr. Suraj Chowre for his beautiful talk. Very excellent cosmetic surgeon and shown very nice results. Yes. Our president to join. बोला ना त्यांना राहू द्या म्हणा I would like to request Dr. Suchit Bagde to felicitate Dr. Vasnik sir. Dr. Rashmi Baisare madam will be felicitated by Dr. Pradeep Pajare sir.
Yes, sir.
There was lucky draw from the one company. Rajesh Machirke is there. Rajesh? Dr. Demre madam has some announcements, please.
Dear delegates, all the speaker and faculties, there are some bullet points for you just to remember. 5 p.m. there will be the high tea, because yesterday no one was knowing, even though the flyers were put in the group for 3 to 4 times. High tea will be served at 5 o'clock. We have a valedictory. After that we have a public forum, and there will be a dinner served to each and everyone, those who are there. We have kept a box in the reception as a feedback drawback. Kindly submit your feedbacks, because this is the only way where we can correct ourselves. We can do better whenever there is next time. Feedback form is not printed 8. You can just write down your name, your mobile number, and just give the feedbacks. Thank you so much.
For our next session, I would like to invite our chairpersons, Dr. Niladhar Harke sir, Dr. Sunil Bhaisare sir, Dr. Rahul Sakre sir, Dr. Sneha Ramtike madam.
There is a lucky draw and there will be 5 winners from the lucky draw. The company is Atlas Biosciences and it will be declared at the time of valedictory.
Good afternoon, all of you. I would like to welcome Dr. Nagpur Golate as an MS Ortho and MCH from UK. He is a renowned orthopedic surgeon, specialization in joint replacement and trauma. He is a director of Grace Ortho Care and Multi-Specialty Hospital in Nagpur. Currently, he is a secretary of Vidarbha Orthopedic Society. Please deliver your talk.
Thank you very much, Dr. Rahul. Good afternoon, everyone. So before I start, I wish to thank President of Baho, respected Dr. Trishala Dhemre ma'am, Organizing Chairman, respected Dr. Gedam sir, and Organizing Secretary, respected Dr. Shankar Khobragade sir, for giving me this opportunity to present. I'll be talking on knee replacement and sharing about our innovative effort to make it more precise. So joint replacement, it's a surgery that is done to replace worn out cartilage due to arthritis. The etiology of arthritis is multifactorial, though age-related wear and tear is one of the most common cause. So for a disabled patient, it gives back pain-free mobile life, and rightly so, it has been said to be the surgery of the century. However, to achieve the desired result, a lot of factors have to be addressed. And one of the most important variables that will significantly decide the surgical outcome is surgical execution. That is so, because unlike fracture fixation, where the bone unites in 3 to 4 months and the implant has no further role thereafter, in case of joint replacement, the implants have to sustain weight-bearing loads for many years. So here we can see that humans are bipeds and the loads our joints are subjected to are mostly vertical, especially with the large joints. As we can see, any structure can fail if the alignment is not ideal. Similar principles apply in case of knee replacement. The more precise the alignment, the better the results. As arthroplasty surgeons, one of the feelings that we share in common is that our joints should last for a long time, they should outlive the patient. In most of the cases, it does. But in some cases where it does not, we need to search for the reasons, we need to find out solutions, and we need to implement them. In total knee replacement, one of the main reasons for failure is malalignment. So tibial component alignment is one of the key steps in total knee replacement. If not executed properly, there can be trabecular fracture, bone cement failure, and component subsidence. So the final outcome of malalignment is a poor outcome. And there is a sea of literature that correlates with this. And if we take these studies seriously, then we need to address alignment seriously. So total knee replacement, it involves a series of steps that have to be completed sequentially. Error in one step can affect the next one. A significant amount of evidence exists implying that the most common cause for revision in total knee replacement is error in initial surgical technique. And the first step with tibial alignment is locating the center of the ankle joint. So different soft tissue and bony landmarks have been advocated to locate the center of the talus, that is the ankle joint. These include the second metatarsal, the tibialis anterior, EHL, EDL, dorsalis pedis, and the interior tibial crest. However, there is no consensus on the best method available. So to overcome this confusion associated with multiple options, we propose a simple technique to locate the center of talus and also the distal tibial axis. We hypothesize that this technique can be helpful to cut the tibia perpendicular to the mechanical axis and place the tibial component in proper alignment. So here we can see the steps involved. under C-arm guidance with ankle internally rotated to get a mortise view, a metal rod is used to locate the center of the ankle, and it is further adjusted to align the rod parallel to the mechanical axis of the distal tibia. I generally use a filer to do this. A permanent marker is then used to draw a straight line along this filer. So marking can be done either before or after anesthesia. The mark at times can fade after scrubbing, but this is reinforced after painting and dripping with a sterile marker and covered with an IO-band, which also avoids any skin movement during surgery. Just a small, sorry. So intraoperatively, the mark can be clearly seen through the IO-band. The extramedullary alignment rod is aligned parallel to this mark and is fixed proximally and distally, and rest of the surgical steps are carried out as with any conventional surgery. I use a ETO sterilized spirit level to reconfirm the position before the final cut is made and to complete the surgical steps sequentially. To validate the technique, post-operative measurements were done as described. An anteroposterior X-ray were done with tube at 2 meters and limb in neutral rotation with the patella facing anteriorly. The angle between a line which was parallel to the surface of the tibial component and a line along the long axis of the tibia was calculated on computer and on X-rays. So far, we have used this technique in 30 cases with satisfactory alignment of the tibial component. There were no outliers more than 3 degrees. The average time required to mark was less than 2 minutes, and the average radiation exposure was about 3 to 4 shoots in each case. So here we can see a patient who was operated using this technique. This is just 4 weeks after the surgery. One more patient who was operated recently. The patient is walking comfortably without any assistance just 2 weeks after the surgery. This gentleman, he was operated with right total knee replacement and he's back to all activities without any restrictions. Mobilization is started immediately, even in patients with major comorbidities. So let's see how the present problem has been dealt so far. Intramedullary guides don't have to deal with locating the center of the ankle, and many studies have found them to be better. But surprisingly, 3/4 of orthopedic surgeons use extramedullary guides. However, intramedullary guides can lead to errors in case of marked bowing of tibia, extraarticular deformities, and any previous fracture. There is also a marginally increased risk of embolism with their use. So use of extramedullary alignment guide, it places the onus of responsibility entirely on the surgeon. The distal fixation of the alignment device is determined subjectively. This can cause error in alignment because the ankle center is not always easy to identify, especially in overweight obese patients who have significant soft tissue cover and obscure the ankle anatomy. It can also be difficult when patients have ankle joint arthritis. So using extramedullary guides, it has been reported that only 70 to 80% of patients have the tibial component placement within 3 degrees. So broadly, 3 methods are available to locate the ankle center. These are the functional methods, the morphologic methods, and the percutaneous digitization. And even computer navigation relies on accurate feeding of anatomical reference points by the surgeon. Thus, the center of ankle joint estimation in conventional and navigated surgeries remains more or less the same. And there is a potential variability in the position and number of points which are digitized, and also a variability in the interpretation by the surgeon. This is always can give rise to an error. So almost everything in front of the ankle has been studied and related to estimating the ankle center. Investigators have explored all modalities right from CT, MRI, USG, color Doppler and cadavers to suggest better predictability in locating ankle center. Each study has its limitation and the search for a best landmark still eludes us. So these are few studies which have been attempted to locate the ankle center intraoperatively. Sopti and Maniar et al. Did so using ECG leads under C-arm guidance. They found 120 knees were within the desired alignment and concluded that the technique was reliable and convenient. The other is a very robust study by Mullaji et al. And this is a prospective randomized controlled study on 467 patients. It was a single implant that was used by a single surgeon. And the authors used hip and ankle markers which was fixed to the skin. They did intraop imaging. But the point to be highlighted is that even with utmost precautions and care, still the outliers in navigation were more up to 10% and in conventional up to 20%. So these findings, along with many other studies, have documented that the percentage of outliers, even with experienced surgeons, is around 20 to 25%. So even advanced navigation and mechanical instrumentation, and even robots for that matter, they ultimately rely on a surgeon's visual inspection and clinical judgment, which is subjective and therefore prone to errors. So through this technique, we suggest that clearly defined anatomical structure is better than an estimated point. We believe that with this surgical step, there is a dual benefit of not only locating the center of the ankle, but also the distal tibial axis. However, to be of significant use, the current technique needs to be performed on a large number of patients. It needs to be compared uniformly and observed extensively over a period of time. We have recently published our findings in the Journal of Medical Research and Surgery, which is an index journal. So it's only Mother Earth that is capable of forgiving malalignment. And thank you so much for your kind attention.
We are running late actually. Public forum and a lot of lectures are there. So can discuss with Dr. Ninad afterwards. Thank you.
Thank you, sir, for the talk. I request chairpersons to felicitate Dr. Ninad Golghate, sir. I request Dr. Trishula Dhimre, madam, to join. I invite Dr. Neha Golghate, madam, for the next topic.
Here is Dr. Neha Golghate. Dr. Neha is a MS Ortho, MCH of UK, and she has done her DNB Orthopedics. She is an orthopedic surgeon, one of the rare varieties, and specialization in arthroscopy and sports injury. She is a director of a Grace Orthocare Multispeciality Hospital, Nagpur, and she is recipient of a Ian Kelly Scientific Award in UK. Currently, she is the national head of a women's wing of Indian Orthoscopy Society.
Thank you, sir.
Dr. Neha Golghate, please.
Thank you very much. Good afternoon, everyone. At the outset, I'm Dr. Neha Golghate. At the outset, I would like to thank our organizing team of Bahocon, and especially Dr. Trishula Dhimre ma'am and Shankar Gopragade sir, for giving me this opportunity to present my work today. So, as we all know, India won its first gold medal as a single athlete in this Tokyo Olympics in javelin throw by Mr. Neeraj Chopra. And the same sportsman was struggling with his elbow injury a year back. He was operated with arthroscopic reconstruction, and 1 year later, the same sportsman won the gold medal. Same with Saina Nehwal, who was operated for her anterior cruciate ligament injury, and after which she continues to escalate in her career. So, had these injuries been untreated, India would have lost so many elite players. So studies have shown the patients with untreated ligament or meniscus injuries progress fast with knee arthritis like these. So participation in youth athletics in India continues to rise across all sports over last several decades in India. In 2020 Summer Olympics, there were 126 players involved. However, in 2022, there were 325 players involved in a game. So more number of players, more will be the injury rate. Prevalence of sports injuries was 65% in the study. And out of all the sports injuries, football has got the highest number of sports injuries, followed by hockey and then basketball. The commonest joint involved is a knee joint. So coming to knee joint, knee injuries, first is a meniscus. Meniscus acts as a shock absorber, assisting in a load transmission. So injury to meniscus will affect its important function. Similarly, the anterior cruciate ligament will be get torn when the foot is planted on the floor and fixed on the ground, and femur suddenly twists over the tibia. So ACL will get torn. So in acute injuries, the patient gives specific history that the swelling, doctor, my knee got twisted and swelling appeared after 2 to 3 hours of injury. And then after aspiration, we see lots of hemarthrosis, around 60 to 70 cc of hemarthrosis we can aspirate. However, in chronic presentations, there will be the patient complains of instability of knee, or a giving way sensation, or there will be no confidence of running, and clinical tests will show that Lachman's and anterior drawer tests are positive. Here we can see I can very well translate the tibia over the femur. So once your clinical diagnosis is done, it is time to confirm our diagnosis. X-ray is the basic to rule out any bony injury. Here we can see along with ligament injury, there is a small bony injury over there. However, MRI remains the mainstay of investigation. It confirms our diagnosis. After confirmation of diagnosis, we decide which cases need arthroscopy. So cases with meniscus tears, anterior cruciate or posterior cruciate ligament tears, loose bodies or osteochondral fragments, etc. need arthroscopy. So examination under anesthesia is helpful as the muscle forces are nullified with the help of anesthesia, and it gives the exact idea of laxity of the joint. We also examine the range of motion of the joint, if there is any fixed flexion deformity or if there is any restriction of the knee range of motion. Here we can see in this patient, there is a full range of motion. Also, we check the stability in all the planes, like medial-lateral plane. Here I'm checking anteroposterior plane. The knee seems anteroposteriorly stable. And also the rotatory instability also is checked. So, coming to interesting cases, this was a 22-year-old gentleman who had a twisting of injury while playing, and he came with the history of instability of the knee. The MRI confirmed the diagnosis that this is posterior is the posterior cruciate ligament, and anteriorly it's anterior cruciate ligament. It is torn from the femoral end. So he was operated with arthroscopic ACL reconstruction. A 4 mm scope is inserted with a small stab incision, and another similar stab incision is made on the medial side for working. This is the arthroscopic view of the ACL. Here we can see this is the normal ACL for our just knowledge. This is the femur. This is the intercondylar notch. This part is the tibia, and this is the reconstructed ACL. So 2 tunnels are made, and one in the femur and one in the tibia. And after that, a semitendinosus tendon is harvested and autograft is prepared. This graft is then passed through these tunnels and fixed at both the ends. Here we can see I am passing the autograft from tibial tunnel to the femoral tunnel. So this is the reconstructed ACL. This is his 3 months follow-up. The patient is able to sit cross-legged. His knee range of motion is full. He is able to do his active SLR and full without any lag. At the end of 1 year, the patient was able to perform all his athletic activity on a single leg hop. On the operated leg, he is able to hop on that leg. His running speed has come back to his pre-injury level. So this is another case, a 25-year-old BSF Jawan. He had a twisting injury while playing kabaddi. He had stopped all his athletic activities over 6 months because of feeling of instability. So when he presented to me, so clinico-radiological diagnosis confirmed that he had ACL tear. So This is his arthroscopic view, where we can see this is a torn ACL. The ACL is torn from the femoral end. After that, in arthroscopy, we shave the native ACL, which is torn, and then we reconstruct it with the new ACL. So this is at the end of 9 months. This patient sent me a text, a thank you note, saying that today he won the trophy in Kabaddi tournament. So this was his match point. He sent me that video. So now coming to shoulder joint, this joint has got a huge range of motion. So this is an inherently very unstable joint. As we can see here, it is like a golf kept on a tee. So the maximum stability is achieved by ligaments and muscles surrounding it. Any injury will commonly lead to anterior dislocation or anterior-inferior dislocation of the shoulder. The commonest mechanism of this injury is the force is applied when hand is in external rotation and abduction. At that time, when the force is applied, the shoulder suddenly pops out. In acute cases of shoulder dislocation, the contour of the shoulder, which is normal shoulder contour, it is lost on the dislocated side. The acromion becomes very prominent. So this is anteroinferior dislocation of the shoulder. The X-ray is again a diagnostic in cases of acute dislocations. However, in chronic, it is not diagnostic. In chronic cases, the patient complains of recurrent shoulder dislocations. The patient may dislocate 2 to 3 times. Sometimes patient comes with 40 to 50 times of dislocations. And it can dislocate with a trivial activity like taking a bag from the back seat of the car. Patient doesn't have confidence while doing overhead activities. So clinically, in chronic dislocations, the patient would have a sulcus sign like this. So here we can see there is a dip in the just below the acromion. Also, there is a more anterior translation of the humeral head. Crank and Job test is performed like this. The patient is put in external rotation and abduction. The patient feels apprehension that his shoulder might again come out. So this is the case 3. He is a 25-year-old gentleman, right hand dominant. He had a trauma to his right shoulder with instability. Here in the MRI, we can see this is a posterior labrum which is attached to the glenoid. However, the anterior labrum is detached. So this is a Bankhart's lesion. Conventionally, this was operated with open repair or putty plat repair, where because of lots of scarring, the patient had decreased rotations. However, but with the advent of arthroscopy, this is possible with minimally invasive way. The patient under GA, the lateral decubitus position, arthroscope is inserted in the joint. This is the humeral head. This is a Bankhart's lesion, the glenoid, which is the glenoid labrum, which is torn. After repair of the glenoid, you can see a nice bump over there. So at the end of 6 months follow-up, the patient is able to do all his activities. He has got full range of motion, and very importantly, there is no feeling of instability. So not only ligament injury, but even fractures can be fixed arthroscopically. This 28-year-old gentleman had a twisting injury, hem arthrosis, and what mind knows, I see. So this is a very subtle sign here. If you can see, this is a small flake of bone which is in the knee joint. So this was a ACL avulsion injury. MRI confirmed that along with ACL there is a small bony chip which has avulsed. So arthroscopically ACL avulsion was fixed, and at the end of 6 months the patient has got full range of motion. There is anteroposterior stability is maintained. Here are some similar cases of ACL avulsion fractures. In young girls like that, not only recovery is fast, but it is more cosmetically appealing incisions. So to conclude, arthroscopic surgery helps early mobilization, less pain, less blood loss, less hospital stays, and more cosmetically appealing, and better rehabilitation and ultimately better long-term outcome. Thank you.
Thank you, ma'am, for the nice talk. I request the chairpersons to felicitate Dr. Neha Godghate, madam. I invite our next speaker, Dr. Nisha Mishra, madam.
Our next speaker is Dr. Nisha Mishram. She is assistant professor in Department of Pathology at AIIMS Nagpur. She has teaching and research experience of about 14 years, and she has special interest in oncopathology and dermatopathology. I hand over to Nisha, madam.
Thank you very much, sir. A very good evening to all of you. And before I start my presentation, I wish to thank the organizing committee of Bahocon for giving me this opportunity to present my work. So today we'll be talking about the immunofluorescence technique, basically specifically the ANA by indirect immunofluorescence method, and we'll be learning about the different ANA patterns which can lead to help to diagnosis of different cases. So basically, what is immunofluorescence? It is nothing, just a technique which detects the antigen-antibody complexes. These antigen-antibody complexes are pathognomic for in various autoimmune diseases. So this phenomenon, this principle was used for development of various techniques for detection or diagnosis of these autoimmune diseases. Direct immunofluorescence, indirect immunofluorescence with complement fixation, and double immunofluorescence. Out of these, the commonest used are DIF and IF, which we say. So direct can be used for detection of in vivo antibodies, commonly used in skin biopsies and kidney biopsies, while indirect immunofluorescence technique is used for detection of circulating antibodies present in autoimmune disorders like ANA antibodies. So basically, what is anti-nuclear antibody? It is not a single antibody, but a combination or variety of different antibodies which reacts with the different constituents of cells, including DNA, proteins, and ribonucleoproteins, commonly used for the diagnosis of autoimmune diseases. But these are not specific just for the connective tissue diseases. These can also be seen in cancers, in infectious diseases, advanced age, and even can be seen in some healthy individuals. So what is the use of this ANA testing? It can be used for diagnosis, differential diagnosis, disease monitoring, and efficacy observation in systemic autoimmune rheumatic diseases. So what does it detect? It detects the various antibodies against the cellular components, including nuclear components, cytoplasmic, mitotic spindle, and cell membranes. So as we know, this is an exhaustive list, including all the different antibodies which can be detected by this ANA test. What are the different methods? IF, ELISA, immunophase assay, mixed bead immunoassays, and now the newer techniques, including the immunoblot, dot blot, line probe assays, and some automated methods have also been used. Now here I want to press upon that now also we get many requests that do the ELISA, but I really want to tell that whenever you want to do a diagnosis of autoimmune disorders, please go for indirect immunofluorescence with the help of Hep2 cells, because ELISA will just give you the titer. It will not tell you about the type of the antibody, which is very important. So please go for IF, and if IF is positive, you can go for a specific panel. So ICAP, the international consensus for ANA patterns, confirmed that ANA testing by IF using Hep2 cells is the gold standard, because it can give you the reaction strength and the pattern of reaction. And they have described 28 patterns of ANA reactions which are available online, and they can be seen by anyone who is interested in them. Hep2 cells, why we are using them? Because they provide a native protein array of different types of antigens can be seen, and nowadays new assays are there which are also using the rat liver or primate liver. This is important, and this helps in detection of different ANA patterns and determine the ANA titers also. What is the sample preparation? No specific or special sample. The simple serum sample can be used. It can be stored for 7 to 8 days at 2 to 8 degrees Celsius. And if you really want to store them for your research purpose, you can store them at in frozen for up to 6 months. So this is just a technique, and this is indirect immunofluorescence. The commercially available kit contains wells, which contains these HEP2 cells in the primate liver, and the antigen is already there. So when the serum is added, if the antibody is present, it will react. And the second antibody, which has a fluorophore conjugate, it is added. So if the reaction has occurred, it will give the staining. How the results are read? It depends upon the titer and the pattern. So if the titer is less than 1:40, it is considered negative because it can be seen in many 30% of the healthy individuals. 1:40 to 1:60, this is considered as a low titer. Even though it is given positive, it is usually given as 1+ positive reaction. But if the patient is not having any symptoms, further workup is not recommended. So now let's see the interesting part, and I think this is green and black is better than the pink and blue, because here I think many of you will be able to appreciate this pattern. So this is basically done under fluorescent microscopy. So this is the pattern which is homogeneous, and नहीं रेड भी है. So I think here, whenever we talk of HEP2 cells, we are talking of two types of cells. One is mitotically active, and then the second is resting phase. So let's go on to this cell. So this is a cell, this is the cytoplasm, this is the nucleus, which is showing a homogeneous reaction. So the whole of the nucleus is reactive. This is a diffuse homogeneous reaction, and when we see these cells, these are the mitotically active cells, and you can see that this is the chromosomes which are centered, and they are having a dark staining. So, and this is the complementary liver, primate liver, which is also the liver cell nuclei. They are also showing a diffuse homogeneous positivity. This is commonly associated with SLE. This is the next pattern, speckled, which can be both, speckled means dot, or granularity, which can be both fine speckled and coarse speckled, though it is the most common pattern which is seen, but it is the least specific. So now let's see first the resting cells, which are showing a granular fine speckled positivity, and these are the mitotically active cells, and we can see that the centers are negative. So this is a fine speckled pattern. Even the liver nuclei, they are also showing a fine speckled or granular fluorescence. So this is the CoO, antibody against CoO, which is usually seen with Sjogren's, SLE, and polymyositis. This looks very pretty, beautiful. Antibodies against centromere. We can see the resting cells, which are showing multiple dots, discrete speckled, distributed throughout the cell nuclei, and the mitotically active cells are showing a metaphase bar. And this is the primate liver, which is again showing your discrete dots. It is associated with a limited form of progressive systemic sclerosis. This is a nucleolar pattern. Again, we can see that the nucleoli, they have taken up the stain, and this is the liver. Here you can see very fine dots are seen, which are corresponding to your nucleolar pattern. This is associated with anti-RNA polymerase antibody associated with a progressive systemic sclerosis. I'll skip this, and let's see this peripheral rim accentuation, where we can see that these are the cells which are showing a diffuse staining pattern, and there is a peripheral accentuation. This is due to the presence of antibodies against the nuclear membrane, and this is commonly associated with primary biliary cholangitis. The liver cell nuclei, also here you can see that there is a peripheral accentuation or a rim pattern. These all were the nuclear patterns. Now we come to the cytoplasmic pattern. So here we can see that this is the cell nuclei and the cytoplasm, which is showing multiple distinct sharp dots. This is seen in antibodies against Jo, which is commonly associated with polymyositis. This is my favorite pattern. It is called as a goodbye kiss. Here we can see that the mitotically active cells, the chromosomes which are arranged around the equatorial plate, they are showing a fine speckled pattern, and as the cells are dividing, the line goes on decreasing. So at the end, at the telophase, you can see only a dot. So when the two daughter cells, they are dividing and two dots are there, so it seems like they are just touching each other, and it is seen in meningioma, Raynaud's phenomena, and progressive systemic sclerosis. Though this photo is not so nice, but here if you can see some cytoplasmic rings and rods. So this is a cytoplasmic pattern, and these are the mitotically active cells which are showing this mitotic spindle positivity. This, though it is not very specific, but it is associated or seen mainly in patients with hepatitis C infection. So this is how we give the result. First of all, we give the result, whether it is positive or negative, pattern, what is the grade, and what is the estimated titer. And this is at the back of the report where the location, their pattern, the target antigen, and their clinical association is given. So what are the limitations of this method? It is a semi-quantitative method, it lacks harmonization, and the interpretation depends upon the various modalities like your procedure, the efficiency of your fluorescent microscope, and the efficacy of the person who is reading these slides. So to summarize, screening with indirect immunofluorescence for ANA with Hep2 cells is the gold standard. Please go for this test, don't go for ELISA. If this IF by ANA by IF comes out to be positive, and the patient you want to get or you want to know about the more specific antibody, you can go for a line blot assay, which can give you, which has multiple panels like myositis panel, autoimmune panel, hepatitis panel, and you can get an idea of the specific antibody. So that's it. Thank you.
Thank you, ma'am, for the nice talk. I request chairpersons to felicitate Dr. Nisha Mishram, ma'am. Dr. Dhimre, madam, to join.
Next speaker, Bulwa.
I invite Dr. Kavita Dhabate, madam, for the next topic.
Dr. Kavita, please come on the podium. Get ready.
I would like to.
Good afternoon, everyone. First of all, I would like to thank Baho and especially Dr. Shankar Khobragade sir for giving me this opportunity to present before you my topic, yes, blindness due to glaucoma is avoidable. After listening to two talks on the most tough part of our body related to bones, then pathology, we are shifting on to the most beautiful organ, sense organ of our body, that is eyes. Without eyes, you cannot do anything, you cannot see anything. So let us prevent blindness from glaucoma. There is no financial interest in the study. Glaucoma is a leading cause of irreversible blindness. It is the second leading cause of blindness globally and third major cause of blindness in India after cataract and refractive errors. If left untreated, it does get worse over time. Glaucoma can be arrested with treatment, and hence early diagnosis is necessary to treat this preventable cause of blindness. What is glaucoma? Glaucoma is a group of eye conditions that can cause blindness. With all types of glaucoma, the optic nerve connecting the eye to the brain is damaged, and it's usually because of the high intraocular pressure. In the first slide, you can see a patient with primary open-angle glaucoma, where you can see the eye is absolutely, the cornea is clear, the pupil is normal. In the second slide, you can see a patient having acute congestive glaucoma, where there is a lot of congestion, cornea is edematous, and pupil is semi-dilated, not reacting to light. Let us first understand the normal aqueous humor dynamics. The aqueous is produced from the ciliary body, then it is carried through the posterior chamber into the anterior chamber through the pupil, then it is drained through the angle of the anterior chamber through Schlem's canal, trabecular meshwork, Schlem's canal, and to the episcleral veins. So in both the glaucomas, the mechanism of its occurrence is different. In open-angle glaucoma, what happens is either there is excessive secretion of aqueous from the ciliary body, or there is outflow obstruction to the aqueous. So these two mechanisms are very common in open-angle glaucoma, and third mechanism, which is less common, is increase in episcleral venous pressure. In closed-angle glaucoma, what happens is initially there is pupillary block, because of which this aqueous cannot come through this pupil into the anterior chamber, leading to bulging of the iris, and when this peripheral iris comes into contact with the peripheral part of the cornea, there is formation of the peripheral anterior synechiae, thus leading to rise in intraocular pressure. This rise in intraocular pressure then damages the ganglion cells of the optic nerve, thus leading to optic atrophy, which is permanent. There are basically two types of glaucoma, congenital and acquired, both each divided into primary and secondary, out of which we'll be discussing only the primary open-angle glaucoma and a few notes about closed-angle glaucoma. Primary open-angle glaucoma is most common type of glaucoma. It's a silent disease. It is chronic progressive optic neuropathy with characteristic optic disc changes that leads to corresponding visual field defects. It is painless and causes no vision changes, no central vision changes at first. Only the peripheral vision changes are there, which are many times missed by the patient. Some people can have optic nerves that are sensitive to normal eye pressure, which is known as normal tension glaucoma or low tension glaucoma. So this is the triad of the glaucoma. It usually begins without symptoms, hence regular annual eye exams are important to find early signs of damage to optic nerve. Although glaucoma cannot be cured, in most cases it can be successfully controlled. The key to preservation of vision is early diagnosis and treatment. So, what are the risk factors for development of glaucoma? First and the most important is family history of glaucoma. If any of your family member, parents or siblings are suffering from glaucoma, then that person should get his eyes checked. If your age is more than 40, if you are suffering from diabetes or thyroid disease, if you have previous history of blunt injury, or if you are on long-term corticosteroid therapy, especially the topical one, then you are a candidate for development of primary open-angle glaucoma. The myopic patient, they have general tendency to develop primary open-angle glaucoma, whereas hypermetropics, they have tendency to develop the primary angle closure glaucoma. What are the clinical features? Initially, as I told you, initially it is asymptomatic in early stages. You can have headache and eye ache, but it is ignored. Frequent changes in the presbyopic glasses, patchy scotomas in the peripheral field of vision or side vision are seen, and in the late stages, you can have the diminution of central vision as well. The signs are, in initial phases, the anterior segment is absolutely normal, cornea clear, pupil is normal size reacting to light. In advanced cases, patient may have relative afferent pupillary defect and characteristic optic disc changes. And raised intraocular pressure may be there, may not be there. So that means even if your intraocular pressure is normal, you have to get your optic disc examined and visual fields done. So what should we do to diagnose the glaucoma early? The investigations are IOP measurement, optic disc evaluation, visual field examination, gonioscopy, optical coherence tomography, optic disc photography, and central corneal thickness measurement. IOP measurement is a very simple test which can be done on OPD basis by applanation or indentation tonometry. Applanation tonometry is considered better alternative. It's a very simple technique, and nowadays non-contact tonometers are also available. Second test is optic disc evaluation, which is done for structural assessment of the optic nerve, which can be done by direct or indirect ophthalmoscopy. It should be done under full dilatation of the pupil, and at the same time, optic disc photography should be done to document the changes. It should be ideally done annually. Here in the first photograph, you can see this is the optic disc. This central white part, what you are seeing, is the optic cup, and the area between the margin of the optic cup and this margin of the disc is known as the neuroretinal rim, which gets damaged in the glaucoma. So this you can compare normal and abnormal or glaucomatous. There is enlargement of the cup, and the other signs of the glaucoma are there is enlargement of the cup. You can very nicely compare. This is advanced case going into absolute glaucoma stage. So there is enlargement of the cup, nasal shifting, pallor of the disc, cupping of the disc, thinning of the neuroretinal rim, notching of the NRR can be there can be bayoneting sign, and wedge defects in the RNFL can be observed in the inferotemporal and superiotemporal quadrant of the retina near the optic disc. Disc hemorrhages are pathognomonic signs of the normal tension glaucoma or low tension glaucoma. Third test is visual field testing for functional evaluation of the optic nerve. It is done to detect the peripheral visual field loss, which occurs early in primary open-angle glaucoma. Nowadays, only automated perimetry is done. It is indicated in all suspicious discs, especially even many times we get confused. The myopic disc and the primary open-angle glaucoma discs are confusing. So in those cases also it is mandatory. then risk factors, whatever I have mentioned before, those risk factors are present, then you have to get it done. It should be done once or thrice in a year, more frequently with severe disease or with rapid progression. These are the list of the field defects. So we wish to detect glaucoma before this particular stage occurs. If we are successful in that particular thing, then our aim is achieved. Otherwise, if we go to this particular stage, the patient becomes blind and cannot do anything. These are the few of the photographs of automated perimetry being done. This is the normal blind spot which is present, and this is small paracentral scotoma. This is the upper arcuate scotoma with preservation of the central visual field, and this is advanced field showing a small tubular field of vision, central vision, which is left, which is the end stage glaucoma. This is what the patient is seeing. With normal vision, you can see the periphery also very clearly. With advanced glaucoma, you can see only the tunnel vision. This is the absolute scotoma, and this is the relative scotoma. The vision is hampered in this particular case. Next investigation is gonioscopy. Gonioscopy is important to differentiate open angle glaucoma from primary angle closure glaucoma. It's a very simple test. We require only slit lamp and gonioscope to do this, and all the angle structures like trabecular meshwork, Schwalbe's line, scleral spur, and ciliary body band can be seen in the anterior chamber angle. Next investigation is OCT. This is very popular investigation nowadays. It is non-invasive test, and it is done to study the RNFL, retinal nerve fiber layer, and ganglion cell complex of the optic nerve. And this is even helpful to study the three-dimensional structure of the optic nerve. Here you can see small borderline loss of the optic nerve, RNFL is seen. Here there is, this red means the tissue is damaged, the RNFL is damaged in this particular area. Here in the inferior temporal quadrant, there is damage to the ganglion cells. Next investigation is optic disc photography. Photography is very important to document the changes, and it is also important to record the progression of the disease. One photograph you have taken and you compare with the next visit of the patient, then this is very helpful. This is advanced glaucomatous cupping, as you can see from the photography. Next investigation is central corneal thickness by pachymetry. Thinner corneas lead to underestimation of IOP. Optic disc photography, So treatment, primary goal, though the intraocular pressure is not very important, but still maintaining IOP at normal level or less than normal is the primary goal of the treatment. If discovered early enough, medication, regular exams can help slow or prevent vision loss. Medical treatment, laser treatment, and surgical treatment can work. There are many eye drops available, combination drugs, single drug, multiple drugs are available. Oral medications or IV mannitol is given only when the intraocular pressure is above 30 millimeters of mercury. Laser therapy when the medical drugs do not work. And surgical procedure, this is the gold standard procedure done for glaucoma, trabeculectomy, a small tissue of the deep scleral flap containing the trabecular meshwork is removed, and alternate passage for drainage of the aqueous is there. A word about acute angle closure glaucoma. Any patient having sudden diminution of vision, severe eye pain, headache, redness of the eye should be seen. His eye should be examined for this particular thing, corneal edema and dilated pupil, and referred to ophthalmologist.
Thank you so much. Thank you so much, madam. Please conclude. Thank you. Thank you very much.
My take-home message is, after the age of 40, everyone should go for an eye test, as glaucoma is largely asymptomatic and can lead to significant vision loss. Simple test can be done to save your vision. Thank you, ma'am.
Thank you.
Thank you.
I request chairpersons to felicitate Dr. Kavita Dhavade, madam. I request Dr. Dhimre, madam, to join.
Till that time, chairperson. Anki bolwa.
I request Dr. D.S. Raut, sir, to felicitate Dr. Niladhar Ahadke, sir. I request Dr. B.S. Gedam, sir, to felicitate Dr. Sunil Bhaisare, sir. And I request Dr. Suchit Bagde, sir, to felicitate Dr. Rahul Sakhre, sir. So please come up on stage.
Till that time, we can invite next speakers, next chairperson. बोला बोला बोला
Till that time, I invite our next session chairpersons, Dr. Shyam Meshram sir, Dr. Gunjan Ghodeswar sir, Dr. Manisha Bhavatkar madam.
Next speaker. Get ready. Amol.
Our next speaker, Dr. Amol Dubey sir. So please get ready.
One lecture is cancelled, Dr. Aziz Khan sir. So we are going to have collagen disorder, Dr. Amol Dubey sir.
Hello. Dr. Amol Dubey is Associate Professor. He has done his membership and training. He is a life member of Diabetic Association of India, life member of Cardiology Society of India. He has done a certificate course in diabetes from V. Mohan Institute, Chennai. He has done rheumatology training, KGMC, Lucknow. And he has done virology training in the treatment of HCV and HBV. Dr. Amol Dubey.
Thank you very much for the brief introduction. Dear respected chairperson, this is a talk of a large topic to cover so many sub-chapters in this is not possible. So I am just turning my topic and making it more interesting. As you know, we have already 3 talks regarding rheumatology. One is on rheumatoid arthritis, one is on vasculitis, and one another talk on ANA estimation. So I am taking this collagen disorder to a different level. So my agenda will be when to suspect them, then how to confirm, how important they are in the clinical practice, and number 4 is the management. So they are the diseases which are of genetic or acquired in origin. They refers to a condition that causes chronic, long-standing inflammation in the connective tissue. The most common types of collagen vascular diseases are autoimmune diseases, but not all autoimmune diseases are collagen. The delineation of organ involvement is more important than the diagnostic test and labels. Organ involvement governs the treatment decision. The treatment takes into the account of the disease activity at the point of the when the patient present to you. The most important thing that I want to deliver is to have insight about such a condition that can exist in your patient, which whatever specialty the patient may be going to. It may be orthopedics, it may be ophthalmology, it may be gynecology, anything. So these disorders which are acquired, they include rheumatoid arthritis, which I'm not going to talk, systemic sclerosis, systemic lupus erythematosus, polymyositis, dermatomyositis, MCTD, and Sjogren's syndrome. Some examples of genetic collagen vascular disorders are Ehlers-Danlos syndrome, Marfan syndrome, and osteogenesis imperfecta. So today I am just starting the talk with the genetic conditions. The first one is Ehlers-Danlos. We have seen in our undergraduate days or maybe heard about this syndrome, which is called as hypermobile syndrome. It is linked to the chromosome 8p22. It is mutation primarily in the type 3 collagen and some variants also show a type 4 collagen mutation, which regulates the type 1 collagen fibrinogenesis. So there are, how to score them? There are 9 points called by Brinton for the hypermobility. So they are dorsiflexion of the fifth metacarpal joint, more than 90 degree, then opposition of thumb to the volar aspects on the ipsilateral forearm will give 1 more point, then hyperextension of the elbow more than 10 degree, then hyperextension at the knee more than 10 degree, and place of hands on the foot, till the full knee extended will give 1 score. So if the score is 5 or more, we call as the patient is having hypermobility disorder, but it can be not only Ehlers-Danlos, it can be other disorder also. So there are various manifestations depending upon the tissue involved. There may be general fatigue, the patient have premature births. There may be behavioral changes in the form of chronic fatigue syndrome, fibromyalgia. The eye will show epicanthic fold, microcornea, strabismus, myopia. There are blue sclera which can be diagnostic. There may be eversion of the eyelids called as Mettner's signs and also glaucoma. The mouth will have an hypoplasia, the tooth will be disrupted, there may be periodontal disease, there may be fragile oral mucosa. The patients are known to have inguinal hernias. A recurrence of hernia coming to the surgeon, we should keep in mind there may be something related with this connective tissue. The epidermal shows hyperplastic skin, pigmented cigarette paper scars, enhanced scarring. There may be kyphoscoliosis, which is very common in 20 to 30% of the patient. There may be atlantoaxial subluxation. After the rheumatoid arthritis, this becomes one of the important cause of ATL subluxation. Limbs have joints laxity. Digestive system have a GI diverticuli. There may be rectal prolapse. Circulatory system has a different septal defect, congenital heart disease, bicuspid aortic wall, mitral valve prolapse, tricuspid valve prolapse, dilatation of aortic root are common in the patient with ear-led Dan loss. Pulmonary, the patient may have spontaneous pneumothorax or cavitary lesion. Vascular may have hematomas or easy bruisability. The bladder may have prolapse. In gynecology, they can present as a metrorrhagia. They have migraines and they can present as a peripheral neuropathy and vision loss. There are very much different types depending upon various genes that are involved, different type of collagen that are involved, and I will skip this slide. Now coming to the Marfan syndrome, the Marfan syndrome can be diagnosed by the two types of diagnosis criteria. In one, when there is a family history, and in another there is no family history. There is no family history, with the help of aortic root dilatation and the Z score is more than 2 with ectopia lentis. It is diagnostic of Marfan. The other one is there is aortic root dilatation with FBN mutation when found. The third one is there is aortic root dilatation with and systemic score. I am going to describe the systemic score. When the more than 7 points in the systemic score in a patient with aortic dilatation root, they can be Marfan. The fourth one is ectopia lentis and FBN mutation associated with aortic root dilatation also confirms the Marfan. If we have family history, it is become easy. Ectopia lentis and family history gives you Marfan diagnosis. The score, systemic score of more than 10 with a 7 with a family history of Marfan will also diagnose aortic root dilatation in a patient with more than 20 years of age, and family history of Marfan also suggests there is a Marfan syndrome. So we have known these signs, we have been taught in clinics, that is race sign, arachnodactyly, thumb sign, we all know this sign. This is today we are just revising them. So it is an autosomal dominant disorder which has been linked to FBN gene on chromosome 15. The FBN codes for protein called as fibrillin, which is essential for the formation of elastic fibers in the connective tissue, including vessel wall. So with this, when the gene goes abnormal, the patient has a ligament laxity. This is a score which has been given a point. Total score is 20. Whereas we can see various photographs of high arch palate. Then the arm span is more than the height, and the superiotemporal dislocation of the lens is important because the inferiotemporal dislocation suggests homocystinuria. Then osteogenesis imperfecta, I will just show the photograph so that you can know the blue sclera with brittle bones, the malformed bones, severe kyphoscoliosis is this case. Now coming to the acquired form, so there are many symptoms. Patient can have joint pain or joint swelling, fatigue, arthritis, mucocutaneous manifestation, the Raynaud's phenomenon, Zika syndrome, alopecia, myalgia, and some hematopoietic disorder, particularly bicytopenia, will be included in the acquired collagen diseases. One of them is systemic lupus erythematosus. In 2019 criteria is more specific. There are 7 clinical and 3 immunological things to diagnose SLE. So what are they? At the entry criteria, ANA may be positive, more than 1:80, and there are constitutional criteria. They have been given a weightage. If the total score goes to more than 10, then we can diagnose this as a case of SLE. The important being SLE-specific antibodies like anti-dsDNA and anti-Smith antibody. We can see a malar rash, which is difficult to diagnose in Asian Indians, but can be diagnosed easily in a white population. There are various manifestations which has been shown in this photograph, like the pleural manifestation, kidney manifestation, heart, endocrine, blood, and muscle and joint involvement. Treatment is very simple. Treat with hydroxychloroquine, use methotrexate, go for mycophenolate mofetil and azathioprine when the disease is mild to moderate. In a severe with a flare, use a combination of injectable methylprednisolone plus cyclophosphamide. Nowadays, one immunological derivative is available, that is belimumab, which can be added to the standard care of treatment. Then other is systemic sclerosis, which is characterized by fibrosis affecting the skin and internal organ. It is associated with T lymphocyte dysfunction. There may be arterial narrowing, which can cause arteritis and then called gangrene. It is subdivided into limited as well as diffuse, and it is associated with CREST syndrome. We all know CREST syndrome, that is calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. In this diagram, you can see telangiectasia on just below the lower lid in this child. There are sclerodactyly, Raynaud's phenomenon, and the calcinosis cutis is also seen in the X-ray diagram. SS antibodies and organ involvement. Topoisomerase 1 antibodies is positive in these cases. Anti-centromere antibodies will be positive in limited systemic sclerosis with CREST. GI tract involvement associated with reflux, and there may be watermelon stomach. Renal involvement in the form of hypertensive crisis that can go for renal failure. Pulmonary involvement in the form of exertional dyspnea and pulmonary hypertension. The treatment for Raynaud's phenomenon, we can go for avoiding cold, use socks and gloves. Calcium channel blocker, losartan. We can go for tadalafil. Endothelium-1 antagonist, besantan, can also be used and recently advocated. If the patient is going for lung involvement with the ILD, we can use cyclophosphamide 3 pulses and make him onto maintenance dose. Mycophenolate mofetil and tyrosine kinase inhibitor, NINT has been recently used in these cases. Sjogren's syndrome divided into primary and secondary. It is also called as Zika syndrome, dry eye, dry mouth, and polyarthritis. Clinically presented into various manifestations, and the important being vessel involvement and interstitial lung disease. The specific antibodies are anti-Ro and anti-La. The antibody that can be positive as ANA. It is having different involvement, glandular, articular, cutaneous, and pulmonary. And the last one is mixed connective disorder, in which there may be Raynaud's phenomenon, and the patient will have anti-RNP positive. So this is the ANA different pattern that has been already described by Dr. Nisha Meshram from AIIMS Nagpur. So I think my time is over, and I will like to thank you for inviting me.
Thank you, sir. I request chairpersons to felicitate Dr. Amol, sir, along with Dr. Dhimre, madam. Ma'am, please.
Next speaker.
I invite our next speaker, Dr. Amol Dongre, sir.
So our next speaker, Dr. Amol Dongre, sir. He is a renowned oncologist of our city, and presently is heading the Department of Oncology at JNMC Savangi. He is also associated with Alexis Multispeciality Hospital. He has a lot of national and international publication to his credit. So over to Dr. Amol Dongre, sir.
Yeah. Thank you, chairpersons, and thank you, Team Bahocon, for giving me this opportunity. So, when Dr. Khobragade sir asked me about the lecture on oncology, so he said, Amol, just give us a brief discussion about how to, identify patients in OPD. So I thought this would be a better thing rather than, presenting all the signs and symptoms. History, mystery, and victory over cancer. So history meaning what, 4 decades back we have in oncology, how cancer, mystifies itself, and how victory over cancer has achieved in recent years. So this is a paper in NEGM way back in 1948 where, they have seen that almost 2,852 children with newly diagnosed ALL, and you can see how this is the Kaplan-Meier survival curve, how the cure rate have improved from somewhere around 11% way back in 1962 to 91% in 2007. So that is how we achieved a victory over cancer. This is about a pediatric ALL, which is still a curable disease. So why cancer? Almost 9.6 million people die each year from cancer, and that's more than HIV, AIDS, malaria, and TB combined. And by 2030, experts project cancer death to rise to almost 13 million if we don't act now. And what happens when we act? More than one-third cancers can be prevented. About one-third can be cured if detected early and treated. And we can save up to 3.7 million lives every year. So we know more about cancer than ever before today if we talk about today. Research and innovation, we have witnessed extraordinary breakthroughs in medicine, diagnosis, and scientific knowledge. We are seeing since yesterday in this conference also, we have many innovations. So we know reducing risk factors, increasing prevention, and improving cancer diagnosis, treatment, and care. So what's the impact of this? So the United Nations, WHO, and other UN agencies have recognized the urgent need for global commitment. And when leaders speak up and take action, we give ourselves a chance to make history and to move towards a world without cancer. And how to bring that change? By raising the public and political literacy and understanding around cancer, we reduce fear. We increase understanding, we dispel myths and conceptions, and change behaviors and attitudes. So what are the myths? Creates a negative cycle that accentuates our fear. We have to remove this. There's no cure or there's nothing that can be done about cancer. This is the most important myth. And our fears can prevent us from seeking early detection or to delay or avoid treatment care altogether. Also, diagnosis at later stage or not seeking treatment at all, this can result in worse outcome. Also, beyond this physical, mental, and emotional impact, consider cancer not just the physical impact of cancer, but respect the emotional, sexual, and social well-being of each individual and their career. Quality cancer care includes preserving dignity, respect, and privacy. It also needs support and care, love. Body image and sexual well-being, removal of part of body, hair loss, speech impairment, or urinary incontinence can affect the way patients look and feel about themselves. So what about cancer awareness? How is cancer caused? We all know, I'm just skipping this slide. It is basically a rapid proliferation of cells, rapid uncontrolled proliferation of cells. And who can get cancers? Almost anyone can get cancer, right from a day-old child to 100 years old gentleman can get cancer. So risk factors, again, most common in our country is tobacco, then reproductive alcohol, ionizing radiation, physical inactivity. Prevention, yes, we can prevent almost 2/3 of all cancers may be prevented by avoiding tobacco, avoiding alcohol consumption, eating adequate fruits, knowing family history of cancer, and limiting sun exposure or radiation. Now, family history is something which is very important nowadays. And these are the warning signs, if we are sitting in OPD and any of this, if persists for a longer period, like a persistent headache, even if a patient goes to a neurologist or a general physician, persistent headache, one needs to rule out. Shortness of breath, again, our country, TB is most common, but definitely if the patient is not responding to AKT for 1 month, definitely one should suspect. Cough or hoarse voice that refuse to go, indigestion or difficulty in swallowing, loss of appetite, unexplained weight loss, a sore or bruise that does not heal, a mouth ulcer, change in bowel or bladder habits, unexplained change to fingernails, blood in urine, stool, a mole that changes shape, size or bleeds, and unexplained weight loss or tiredness. So, you always also see we are changing pattern. All stomach cancers are on the rise. Lung cancer up in the metros. Oral cancer rising in men. Breast cancer zooming in metros in younger females. Reason being more of a Western lifestyle. Increasing trend of cancer in upper part of stomach. Decreased trend in lower part of stomach. So, these are the changing patterns what we see in last 2 decades, and mostly because more, urbanization and more Western lifestyle modification. Now coming to the survival and stage of diagnosis. So you can see the 10-year survival for 8 type of cancer if we combine. So if we diagnose early, almost around stage 1 to stage 2, it is 81% survival. But if we diagnose late, then the survival drops down to 26%. So coming to the cancer care, 1998 a transformative years of 20 and then our path forward. So 20 years ago, cancer treated primarily based on histology, location, and size. I'm sorry. And even the pathologists know that now we have moved on from histology to molecular oncology. Roughly 200 fewer treatment options than today, and there are 3 treatment modalities with limited supportive care. Surgery, chemo, and radiation. So, but wait, there's more to it. Change in the paradigm of cancer management, change in the treatment approach and planning, new modalities of treatment. So, we have down mortality and survivorship is up. Progress by many means like treatment, newer therapies, newer modalities of radiation, precision medicine, immunotherapy, prevention for infection-related cancers, cancer susceptibility genes, and drug and surgical risk, quality of life better, and survivorship better. So the change in the treatment approach and planning, it's like no one size fits all approach, era of personalized medicine and precision oncology and targeted therapies. So precision medicine is what exactly? Science serving patients. We have germline mutation, we have somatic, and then we have personalized care. So what is the difference past and now? Initially it was late stage diagnosis, now early detection. Risky surgery is now robotic assistance and standard options, and now it is precision medicine. So what is exactly precision oncology? It is an innovative approach. Treatment is specially designed and target to unique form of cancer. It's the science of using each patient's individual genetics that gene are mutated, causing the cancer to grow to create a treatment protocol just for them based on those genetic mutations. Like if I take example of lung cancer, it's an oncogenically addicted tumor. There are so many driver mutation. So if we find a one driver mutation, we can target that particular mutation, and that is how the survival even in a stage 4 can increase now. So this is a gene mutation which are actually driving cancer. So the European Society of Medical Oncology has defined personalized medicine can be best described as the right medicine for the right patient at the right time. So this is a personalized cancer genome analysis. What is exactly precision medicine? It is the interpreting the story of genes. So suppose patient A has one type of cancer, we detect mutation. There's a particular drug which is available for that particular mutation, and that is how we can treat. So the rise of target therapy, you can see there's a lot many articles. Recently there's article published in Times of India about drug palbociclib in breast cancer. The prices have dropped down from 1 lakh to almost 10,000. What is the benefit? It is more precise, no off-target hits, avoiding collateral damage. Many of them are oral therapies, avoid repeated admissions, and lesser admission reduces hospitalization, reducing the overall cost. So cancer classified by molecular abnormality and site of origin. So we can have these all targeted therapies. The first target drug is rituximab, which is way back in 1997 for lymphomas. Then we have trastuzumab for breast cancer. Then we have imatinib for the dreaded disease, chronic myeloid leukemia. And then at present, we have more than 100 plus FDA approved target cancer drug indications. So if you see this slide, these are all type of malignancies human can have, and these are all type of drugs which are in pipeline, which are available, few are in phase 3 trials. Apart from that, there are small molecule tyrosine kinase inhibitors like imatinib for CML, dasatinib for CML, nilotinib, gefitinib for lung cancer. So they most intensively for drug development are plasma membrane associated protein tyrosine kinase, and there are 8 FDA approved drugs which are available as present, and there are still many more in pipeline. And these are the monoclonal antibodies, again rituximab, daratumumab, brentuximab for other type of blood cancers and lymphomas. So, and these are certain trials which are going on. So we know the pathways in cancer. They grow in the absence of growth signals. They evade the normal signal that stop growth. So very simplified is basically the pathways. Whenever we switch on the light, there's main power supply, then switch, then wire, then bulb connected, then bulb filament. So what exactly this target therapy or precision oncology, the newer therapy, it switch off the main power. It either cuts the wire or remove the bulb from socket. What chemotherapy used to do previously, it just breaks the bulb, and that's why all the side effects associated with chemotherapy has now vanished. Since people are using targeted therapy, we don't have the collateral damage, we don't have the side effects of what chemotherapy used to have. And these are important difference between immunotherapy and chemotherapy. So exactly, immunotherapy stimulates patient's own immune system to attack cancer cells, and response may continue after treatment ends, and interpretation of imaging and response may be complicated, but then yes, we do use certain criteria for immunological therapies, and there is associated specific pattern of immune-related side effects. Chemotherapy directly kills cancer cell, and it also kills indiscriminately other cells also. And these are the immunotherapy drugs which are FDA approved from 2011 till date. There are a lot many drugs which are available. So these are the FDA approved drugs. Again, if we see the pathology testing, we have single gene testing and panel testing. Nowadays, we do liquid biopsy. If biopsy is not possible, we can detect circulating tumor DNA or cell-free DNA where tissue quantity is inadequate for mutation testing or patient unwilling to undergo biopsy, because there's a lot of myth that biopsy can increase the cancer cells. NGS and other technologies have made it possible to identify all the mutations in a tumor tissue in very short time. So basically, I just conclude this with my last slide. So cancer is largely a preventable tragedy. Cancer screening can save precious life. Cancer is curable if detected early, and there's an era of personalized medicine where target therapy is a need of our. With this, I thank Team Bahocon for giving me this opportunity. Thank you.
Thank you, sir. I request the chairpersons to felicitate Dr. Amol, sir. I request Dr. Neha Godghate, madam, to felicitate chairpersons, and I request Dr. Yogendra Bansor, sir, to felicitate Dr. Gunjan, sir.
MOC? Dr. Ashish Bhavatkar, next MOC. Dr. Ritesh Borkar, sir, please come. Bhavatkar, please. Take over. Thank you, madam.
Hello. I would like to invite Dr. Sanjeev, our chairpersons, Dr. Sanjeev Chahande sir, Dr. Varsha Kose ma'am, and Dr. Rishikesh Awade sir. Now I would like to invite Dr. Pradeep Bazare sir for his talk.
Namo Buddhaya and Jai Bhim to all. At the outset, I want to congratulate our first dynamic president, Trishla Madam, Dr. Shankar Khobragade sir, for the excellent this Bahocon conference, and I thank them to allow me to present my presentation on vaccination special situations, especially in the children. I will be restricting my talk to the pediatric age group only. We all know about the vaccinations, the routine vaccination by the government sector and as advised by the Indian Academy of Pediatrics. But in day-to-day practice, we will definitely come across certain situations where we will be asking ourselves, or we will be trapped what exactly to do, go ahead, when to go ahead, whether to go ahead or not. So I will be taking up these special situations. So the first one is vaccination in preterm and low birth weight babies. So all the vaccines can be administered as per the schedule according to the chronological age, irrespective of the birth weight and the maturity or the gestational age. The BCG vaccine and the OPV vaccine can safely be and effectively given to the preterm and the low birth weight babies and or at the time of discharge. The only thing is with hepatitis B, If the baby is weighing more than 2 kgs, you can give anytime after birth. But if the baby is less than 2 kgs, you should wait ideally till 1 month of age. The catch here is if the baby is born to an the HBsAg positive mother. So this is one exception where the babies with less than 2 kgs born to an HBs positive mother, you can give hepatitis B vaccine along with hepatitis B immunoglobulin within 12 hours of the birth. Along with the schedule, there is a change in the schedule with 1 month, 2 month and 6 month at the additional doses. Now, if the babies or the children are receiving corticosteroid or any other immunosuppressant therapy, so all killed vaccines are safe if the child is receiving steroids, but their efficacy can be low. Regarding the live vaccines, if the children are receiving high doses of corticosteroids, that is more than 2 mg per kg per day or more than 20 mg per day, then for 2 weeks, then the live vaccine should not be given unless the steroids have been discontinued for at least 1 month. The children on lesser doses of steroids or those on inhaled or topical steroid therapy can be safely and effectively given their appropriate vaccines without any delay. On immunosuppressive therapy other than steroids, all live vaccines have to be postponed. Now, hyposplenia or asplenia, the commonest scenario we come across day-to-day practice is the sickle cell SS pattern. There is a high risk of serious infections. Today there was one case presentation from our institute also with encapsulated organism. In addition to the routine vaccination, we are already promoting the pneumococcal vaccine conjugate and polysaccharide, Hib vaccine, meningococcal and typhoid vaccine to the patient with asplenia or hyposplenia. If we plan a splenectomy, these vaccines, this above mentioned vaccines should be given at least 2 weeks prior to the splenectomy for superior immunological response. But if we have to undergo an emergency splenectomy, vaccination should be given 2 weeks after splenectomy. All live vaccines can be given safely in these children. Now, regarding the congenital immunodeficiencies, if the child is suffering from severe B cell immunodeficiency like X-linked A-gamma globulinemia, live vaccines like OPV, BCG, oral typhoid, or live attenuated influenza vaccines are contraindicated. You cannot give live vaccines. The measles and varicella may be given, but they are less efficient, and inactive vaccines can be given, but they are still inefficient in this one. So less severe type of B cell deficiencies like IgA or IgG subclass deficiency, only OPV is contraindicated. All other vaccines can be given. In severe T cell immunodeficiency, all live vaccines are contraindicated and all vaccines are ineffective. And this is a peculiar situation because we give BCG at birth. This BCG vaccine can cause disseminated disease in the patient. In combined immunodeficiency like D. George or Westcott-Aldrich or ataxia telangiectasia, inactivated vaccines may be given, but live vaccines are contraindicated. In complementary deficiency, all vaccines may be given safely. Pneumococcal, Hib, and meningococcal vaccines are particularly indicated in these children. In phagocytic defects like CGD, only live vaccines are contraindicated and other vaccines can be given safely. Now, peculiar this day-to-day practice, there is history of allergy to some of the other things. If the first time immunization is to be done and with vaccine is contraindicated in a child with a history of serious hypersensitivity or anaphylaxis to any of the vaccine component, if there is a known that any of the vaccine component he is allergic, please don't give that vaccine. Please check for the stabilizers, the buffers, the preservatives, the antibiotics and residue from the manufacturing process, and please cross-check whether he is allergic to any of this component, and if he is there, please don't give this vaccine. In the history of serious egg allergy, influenza and yellow fever vaccine is contraindicated, but MMR vaccine can be given. And in history of hypersensitivity, please carefully give the inactive mouse brain JE vaccine and monitor this patient's post-vaccine. If there is a prior serious hypersensitivity reaction or anaphylaxis to a particular vaccine, never give it again. And at least 15 minutes watchful period post-vaccination in your clinic should be there and with resuscitation equipment kept ready. Now, another tricky situations, children with bleeding disorders or on anticoagulants like hemophilics, there is always a risk of bleeding after intramuscular injections. For vaccines that have to be given only by intramuscular route, please schedule your vaccine shortly after administration of the clotting factor replacement therapy. You can use a 23 gauge needle or even a smaller needle. Firm pressures without rubbing should be applied for at least 5 to 10 minutes. And vaccines like hip vaccine, IPV, PPCV can be given subcutaneous also, though they are routinely given intramuscular. Now, if the parents complain that my child is ill, can I go ahead with the vaccination? For moderate and severe illnesses, please postpone the vaccines, and parents are instructed to return for vaccination when the illness resolves, because there can be lower immunogenicity or vaccine failure during the moderate or severe illnesses. Please avoid, this also helps in avoid the superimposing vaccine reaction to the underlying illness or attributing these to the underlying illness. For minor illnesses like URI, gastroenteritis or otitis media, you can go ahead with the routine vaccinations. Now, a bit of immunization in pregnancy. All live vaccines are generally contraindicated in pregnancy. A peculiar situation can occur if the lady has to travel abroad and she wants to have a yellow fever vaccine. So yellow fever vaccine should be avoided as far as possible. If travel is unavoidable, this yellow fever vaccine can be given. Measles, MMR, varicella are contraindicated in pregnancy, and avoid pregnancy if you have received this vaccine for at least 1 month. Now, what happens if the vaccine is inadvertently given during pregnancy or pregnancy occurs within 4 weeks of vaccination? The recommendation is, please do not, the termination of pregnancy is not recommended, as there is no increased risk of congenital anomalies in the infants born because the mother has received vaccinations. Now, all inactivated vaccines can be safely given during pregnancy. Influenza, hepatitis B vaccine is given. Rabies vaccine can be given during pregnancy if it is indicated. A bit of lactation. All inactivated vaccines like toxoid conjugates and subunits are safe and pose no harm to the babies. Live vaccines, most of the live vaccines will multiply in the body, but generally they are not excreted in the milk. Rubella vaccine may excrete in the milk, but either there is no infection or it can cause mild asymptomatic infection to the baby. The only exception is yellow fever vaccine. The virus transmits in the breast milk and cause infantile meningoencephalitis. So avoid it should be avoided in breastfed mothers, or you have to interrupt the breastfeeding for at least 10 days post-vaccination viremia period. In immunocompromised, so in general principle says all inactivated vaccines are safe, but the immunogenicity and efficacy may be lower. In severe immunodeficiency, if the CD4 count is less than 15%, all vaccines are contraindicated, but mild and moderate, you can be given if it benefits outweighs the risk. Hepatitis B, more doses with more higher potency. Major contaminated wounds, like in that, you have to, apart from tetanus immunoglobulin, you have to give tetanus. Even if he has received 3 doses of tetanus in the past. Regarding the HIV affected children, if they are asymptomatic, BCG can be given, or these routine vaccines are given, but if they are symptomatic, these vaccines are usually not given. Now, this is an important slide. Antibody containing products like whole blood pack, RBCs, plasma, immunoglobulin, hyperimmune, these are the day in and out we are using. The things I will go fast. There are two vaccines at least, the varicella and the MMR vaccines cannot be used if you are using the immunoglobulins for the next 3 to 4 months. And if you use blood, packed blood cells, there is no contraindication, but RBC and packed blood cells you have used for next 6 months, you cannot vaccinate the child with MMR and varicella. whole plasma, 7 months. Regarding IVIG, 8 months to 10 to 6 months. With this, I will conclude my talk. Thank you very much.
Thank you, sir. Nice discussion. Next speaker is Dr. Vaishali Walke. She is professor in pathology.
Please. Hello. I would request the chairpersons to felicitate our esteemed speaker, Dr. Pazare, sir.
Dr. Demre Madam, please felicitate Dr. Pazare for past secretary award and today's speaker award. Thank you.
Our chairpersons to join them.
Please join. Next speaker, Vaishali Walke. Last lecture of the day.
Now I will request Dr. Vaishali Walke ma'am to present her talk.
Thank you, chairpersons and the organizing team Bahocon 23 for inviting me. I'll be giving you the overview of screening modalities in cervical cancer.
Next talk is an important topic, cervical cancer screening, past, present and future. Dr. Vaishali Walke madam is professor in pathology. She has worked in various capacities at GMC, IGMC Nagpur and JJ Hospital, Mumbai. She has many research publications in various index journals. Madam, start your talk.
Thank you, ma'am. So I'll be covering my talk on this topics, that is disease burden, modalities advocated for screening, and the treatment recommendation. If time permits, I will deal with these treatment recommendations in detail, otherwise I touch upon this. So when we talk about cervical cancer, we know that almost 85% of new cases of cervical cancer are detected, and it is the 90% deaths are attributed to cervical cancer. And we all know more than 75% of cervical cancers are because of HPV infection, and it is said to be preventable. So the cause of this disease or malignancy is HPV. We all know that it is HPV 16 and 18, which are high-risk viruses. Apart from these, there are few there's more, that is 31, 33, 35, and all are these responsible for the malignancies, while HPV 6 and 11 are low-risk viruses which are responsible for anogenital warts. So these are some of the risk factors. So early initiation of sexual activity, HIV infection, sexually transmitted diseases, and high parity pose more risk for the cervical malignancy. So when we see this graph, we see that HPV infection, as the person is exposed to this virus, it will take some time to have an HPV infection, and which may have the body's defense mechanism may clear this infection, or there is also there is a disease progression at around second to third decade, and later on it may lead to intraepithelial malignancies or pre-invasive cancers, and later on cancer. So this what pointer is not working. So this is the graph is important to know because this is the period where we plan our this screening modalities. So this when exposed to these risk factors. So when it is low risk viruses, it is episomal infection which leads to this condyloma, and there is evidence of regression also. When it is this high risk viruses, there is integration of this high risk viruses genome into the nuclei, and which leads to this pre-malignant condition CIN1 or LCL, and there is again, if there is persistence of HPV infection, it may lead to high grade lesions in situ and thereafter invasive malignancies. So what this US Preventive Service and Task Force recommends that it is grade of recommendation is that when for the screening modalities, that when the patient is, or the person, or the female is at the less than 21 years of age, there is no screening is recommended. It is grade D recommendation. While in the age group of 21 to 29, cytology alone is said to be the modality for screening, which is over a period of 3 years. So every 3 years, the female should be screened during the period of 21 to 29. While this American Cancer Society says that FDA approved screening tests are available and they are approved more than 25 years of age. So some scientific bodies say that we can initiate HPV screening after 25 years. While this US Preventive Service Task Force says that we should, in this period, we should go for cytology alone. So when the age is around 30 to 65 years, so if we are going for this methodology of cytology screening, that is PAP test, then it is for every 3 years we should go, that is A grade of recommendation. If we are going this high-risk HPV testing, it should be done every 5 years. Again, it is a grade A recommendation, and co-testing of HPV and cytology also has a grade A recommendation. After age of 65 years, if there is no previous positive results, then we cannot, the screening is not required. Also, the patients of hysterectomy with the removal of cervix doesn't also need. So, when we say cytology alone, yes, but can be, but it has a low sensitivity. So, when it is a low sensitivity, we have a best modality which has a high sensitivity, that is HPV testing, and which is being recommended. So, coming to the routinely or advocated test modality, that is pap smear, we all know. So it is a sampling of cervical surface and the endocervical canal, which is an easy, simple and non-invasive test to detect precancerous. And in the previous literature says that it has reduced 20 to 60% of mortality of cervical cancer. So this is nothing but, he is one of the great scientists, that is George Papanicolaou. He has invented this PAP test, and he has first initiated this on guinea pigs, and then he published his research, that is on the cells shared in the cervix. So this is the Ares spatula. I will not go into details. So these are the collection modalities. So immediate fixation in 95% ethanol is recommended when we are talking about PAP test, or if we are doing this screening in the camps, then it is a dry fixation or spray fixation can also be. With the advanced technologies, we have this LBC. It has its own advantages. So this is LBC, the FDA approved modalities are thin prep, sure prep. So if it is a conventional smear, and this is a sure path which has a small 13 mm diameter of smear preparation, and this is the thin prep. So LBC, when we talk about conventional smear, it has some limitations. So inadequacy rate is around 8%. False negativity is also there because of contamination with blood and mucus. So with this, to overcome these limitations, we have this LBC, but Cochrane systematic reviews and meta-analysis says that there is no difference when we talk about cytological modalities in picking up early precursor lesions. So this is Bethesda, the Bible book of this cytology screening, and it contains these terminologies which should be consistent with the laboratory to laboratory. And this is how we report, that is, which type of sample, whether it is a pap smear, conventional or LBC prepared, whether the specimen is adequate, whether it is negative for intraepithelial malignancy or it is epithelial lesion is present. So this is what is new with Bethesda 2014 is that previously we used to report endocervical component present and that inadequacy was decided. Now endocervical component, even if it is not present, we can report. So these are the normal cells, superficial cells, these are intermediate cells, normal component, and these are endocervical cells. So these are the epithelial cell abnormalities which limit clear categorization, that is why they are called atypical squamous cells. Then this is a low-grade squamous intraepithelial lesion where we can have this nucleus which is more than the 3 times of the normal intermediate cell. In the background, these are typical chylosets of HPV or low-grade lesion. Then these are high-grade lesions or high-grade intraepithelial lesions, SCL we call it as. They are large groups of atypical cells, enlarged nuclei, raised nuclei, raised NC ratio, irregular nuclear membrane and coarse chromatin. Now this is the characteristic smear of invasive squamous cell carcinoma where you have this tumor diathesis, fiber cells, these are tadpole cells and pleomorphic or cytological features of malignancy. Even normal glandular cells like this will endocercal component, but this is the overlapping enlarged nucleus. So these are atypical endocervical cells we may. So what is the advantage? So coming to the another test, that is HPV. So when we talk about HPV as a primary screening test, so it has a high sensitivity, and hence it is advocated by the international agencies, even though it results in higher detection of CIN2. So positive HPV does not mean that woman has cancer, but definitely it means that there is a high risk of getting premalignant lesions. So what are the tests available are these COBAs, which detects the HPV DNA, high-risk DNA. These are Optima and hybrid capture. This table is a busy table which shows this difference. And so what is this? So hybrid capture can also be utilized for this primary screening test. Another modality is colposcopy, which is a triage test after this primary screening test. So we all know that it is a visual inspection after application of acetic acid or Lugol's iodine. These are the CIN 1, 2 and 3. Short of time, I will not go in detail. So another triage test after primary screening is HPV genotyping, then cytology, VI, colposcopy. These may be used alternative to each other in sequence also. So what is the status when we talk about HIV positive or HIV known females or immunocompromised individuals? It is said that they should be annually screened every 3 years till the age, every year annually for 3 years, and then every 3 years, and up till the age of 30. So treatment guidelines, when the patient's age, they have divided the treatment guidelines based on this age, because in less than 25 years, there is a lower chance or there is spontaneous regression and progression to disease less. So the treatment guidelines are mostly divided less than 20 and more than 25. So I will not go in much details this. So immunization, so the CDC recommends this immunization for HPV 2 doses, and even though the patient is put on vaccination, HPV vaccination, he should be screened.
Madam, can you conclude, please? Just give the messages, what you want to say.
Yes, so if there is intensive vaccination, we may, and screening modality, we may reach to the baseline, and so that we can reduce this, eliminate this cervical cancer. This is the summary of this test. And the newer modalities which are under research are this HPV antibodies, oncoprotein DNA methylation, or we can have this dual staining or cytology smears. So what's new about this is that cytology is a modality when the age of the patient is less than 30 years. HPV primary screening is the modality of choice. It is recommended by American Society of Cancer at the age of 25. So in HPV, if you are using pap smear as a cytology, it should be every 3 years, or if you are using HPV, it should be every 5 years. So immunization with HPV has no effect on screening, and HPV is a modality of preference in general population. And self-sampling is also advocated when if it is comfortable or patient is comfortable or educated. So even though the patient is collecting vaginal sample, it will give good results, or it is comparable results to other modalities. So I thank again to the audience for patient listening.
I would like to invite chairpersons to felicitate Dr. Vaishali ma'am. Dr. Khobrakade sir and Dr. Dhemre ma'am to join them. I would request Dr. Khobrakade sir to felicitate Dr. Rishikesh Abode sir. Yeah. With this, we come to the end of this session. Now we will proceed with the valedictory function.
Jai Bhim, Namo Buddhaya. A very good evening to one and all. We now start with a valedictory function. We'll begin with welcoming our dignitaries. We have amongst us Bhadant Sangaratna Manke. I request Dr. Gedam sir to please escort our chief guest. Just a minute, sir. Excuse us.
सुरू करा येस येस नंतर जॉईन नाही या अजेंडामध्ये
Our guest of honor is Dr. M.S. Pimpalgaonkar sir, a senior member and a founding president of our Babasaheb Ambedkar Health Organization. I request our president, Dr. Trishula Dhimre madam, to escort sir.
Dr. Pimpalgaonkar sir is there? Okay, he is not there, no problem. Banteji will take 10 minutes. Till that time, we'll start our this validity function.
Our guest of honor, Dr. B.G. Wagmare sir. I request Dr. Shankar Khobragade sir to escort sir to the dais. Dr. Wagmare sir is a senior physician. He is ex-head of the department and professor, retired from GMC Nagpur. He was ex-DMER Maharashtra State. Welcome, sir. I request our scientific chairwoman, Dr. Manisha Dhanpalwar madam, and our organizing and our secretary of BAHO, Dr. Sanjeevani Lanjewar, to occupy the chairs on the dais. Actually, Dr. Gedam sir and Dr. Khobragade sir to please join and occupy their respective seats on the dais. Once our guests comes, we will escort them. I welcome all dignitaries on the dais. Buddhism is a great religion bestowed upon humanity by Tathagat Gautam Buddha. Param Pujya Dr. Babasaheb Ambedkar enlightened the Bahujans with his great religion. Now I call upon Dr. Sandeep Meshram and Dr. Suhas Ambade to pay a wholehearted tribute to the Mahamanav Dr. Babasaheb Ambedkar and all Mahamanavs. Dr. Babasaheb Ambedkar, Tathagat Bhagwan Gautam Buddha.
Hello.
A valedictory inaugural tribute from Dr. Sandeep Meshram and Dr. Suhas Ambade.
Hello. Hello.
Dr. Sandeep Meshram is a well-known anesthetist and a wonderful singer. Dr. Suhas Ambade sir is also a well-known personality amongst us. Our association BAHO, that is Babasaheb Ambedkar Health Association, Health Organization, is based on the principles of Tathagat Bhagwan Gautam Buddha and Dr. Babasaheb Ambedkar. The theme of our Bahocon, that is Educate, Unite and Implement, is inspired by Dr. Babasaheb Ambedkar's Educate, Unite and Agitate. Excuse us for some technical glitches. It had been a wonderful journey of this Bahocon, and all must have gained a lot of knowledge from the various talks and lectures during these 2 days. We even had a wonderful cultural night at Hotel Center Point, and all must have enjoyed it. And now here we have gathered to acknowledge the hard work of all the organizing team and all those who performed in the cultural night as well as presented their papers and talks.
Sorry for the technical
हे भीमराया तुझ्या पासूनी मिळे आम्हा चेतना मानवा घे अमुची वंदना हे भीमराया तुझ्या पासूनी मिळे आम्हा चेतना मानवा घे अमुची वंदना मानवा घे अमुची वंदना स्वीकारुनिया सेवेचे व्रत केलासी तू समाज जागृत स्वीकारुनिया सेवेचे व्रत केलासी तू समाज जागृत जीवनभर तू दुबळांसाठी भोगिलास यातना मानवा घे अमुची वंदना मानवा घे अमुची वंदना कणा कणानी ज्ञान वेचुनी प्रबुद्ध हो मानवा हो कणा कणानी ज्ञान वेचुनी प्रबुद्ध हो मानवा समतेचा हा प्रकाश दाविला मार्ग तुला रे नवा हो प्रबुद्ध हो मानवा हो कणा कणानी ज्ञान वेचुनी थँक्यू थँक्यू
पूरा वातावरण बुद्धमयी हो गया. थैंक यू डॉक्टर संदीप एंड डॉक्टर सुहास. I request our guest of honor.
I request Dr. Sandeep Meshram and Dr. Suhas Ambedkar to kindly remain on the stage. Your felicitation will be our honor, and you have made this atmosphere Buddhamai. Really, without music, it was excellent. It was great. Yes. We owe you.
Now I request Dr. Pimpalgaonkar sir to felicitate Dr. Sandeep Meshram sir and Dr. Suhas Ambedkar sir. Please sir. Thank you, sir. Thank you, madam. We have amongst us a well-known artist, Mr. Nilesh Ingle. You all must have seen his exemplary art and sculpture during the lunch breaks yesterday and today. Mr. Ingle will present a divine sculpture of Babasaheb Ambedkar and a canvas painting of Tathagat Buddha to Baho. I request our President, Dr. Dembre Madam, our Secretary, Dr. Lanjewar Madam, and our Treasurer, and all our dignitaries to accept these on behalf of Baho. Our chief guest has arrived. Vandami Bhantiji. I request Dr. Gedam sir to escort our chief guest. Bhadanta Sangaratna Manke. He is president of Panaya Metta Sangha, Japan. Artist. Welcome. I humbly request our chief guest to felicitate our artist, Mr. Nilesh Ingle. Thank you very much, Nilesh, for your kind gesture. Thank you, Bhanteji. Thank you, all dignitaries. Now I call upon Sri Naresh Gaikwadji. I request our President and Organizing Chairman to welcome our Chief Guest, Bhadanta Sangaratna Mankeji. A lotus bud is being presented to Bhanteji. Sri Naresh Gaikwadji is associated with Baho since 2014. He has been handling the massive office work of Baho. May it be day or night, may it be sun or rain. Gaikwadji has always been on his toes for any task he was assigned. He is a man with never say no attitude. He has been a big support to many presidents and secretaries of Baho. As an expression of gratitude, we on behalf of Baho bestow upon him the Lifetime Achievement Award, and I request our Founder President Pimpalgaonkar sir and other dignitaries to felicitate Gaikwadji. Bhante ji, Badant Sangaratna Manke ji to felicitate Gaikwad ji.
Without his support, Baho can't run at all. He knows ins and out of Baho. He's a backbone of Baho. So for the official documentation and the entries, as well, he knows each and everyone कौन से साल में कौन सभासद बना था, 1000 रुपए वाला या 5000 वाला, मैं बारिश में गया था या धूप में गया था, उन्होंने मुझे कितना देर रुकाया था, ये भी उन्हें याद है, और किसने उनको जल्दी एंट्री दी थी अपने चेंबर में, वो भी बहुत अच्छे से बताते हैं. So a big round of applause to Gaikwad ji. Thank you. And really he deserves a lifetime Baho's award.
We have conducted the free paper award, presentation award, and we have got the responses from the various medical colleges, and there were 9 papers, out of which the first paper, free paper award, goes to Dr. Ritesh Mate. And this award was sponsored or awarded by a very famous academician, Pali Literature Laureate, Dr. Tarachandra Khandekar, and he has declared to donate cash award by Mr. Tarachandra Khandekar. So I would like to request him to be on the dais and present to Dr. Ritesh Mate. Raj Ratna, please escort the parents, the proud parents. Dr. Ritesh Mate is there. Congratulations, Dr. Ritesh. And would like to request Badanta Sangaratna Manke ji to felicitate along with Tarachandji Khandekar. Ritesh Mate is a cardiac surgeon. He's a cardiovascular surgeon. He is opening and closing the heart, very challenging job. He is attached to super specialty hospital. Thank you, Ritesh. Excellent job you have done yesterday. And Bahocon appreciates your work, and you are a future generation Bahocon. Yes. Cash. We will receive the check or cash from the Mr. Tarachandra Khandekar and will pay to the winner of this free paper award. Okay. Dile?
The check of 20.
Hello.
The check is donated to Baho.
Hello. What else we can ask from our Tathagat and Bhagwan Gautam Buddha as well Ambedkar Babasaheb? There is a huge personality in front of us, and really I'm getting all goosebumps. He is in the memory of his son. He is donating rupees 25,000 to Baho. And in spite he has a neck fracture, he could travel to this hall, and he is here. It's a big honor for every one of us to get this 25,000 rupees, and he wants that we should make a FD of it. And out of that, whatever interest we gather, that will be given every year or whenever we do the conference, that we have given a best paper award, a cash reward. Likewise, whatever from the monetary gain we will have from the FD, that we will be giving for the generations to come. Thank you.
Dr. Praful Sakre, please come. Praful Sakre is the treasurer of Baho.
Yes, I
would like to
request
him.
treasurer to kindly receive. कितने खुश हो गए हो आप अचानक से चमकने लग गए.
Sanjeevani, please join. You are secretary of the Baho. Yes. And Dr. Wagmare sir is requested to felicitate Tarajanji Khandekar by floral lotus bud. Oh. Memento with the memento. इनमें से बोला था. Thank you. There is a felicitation of conference philanthropist Dr. Ravi Wagmare. Bahocon 2023 philanthropist Dr. Ravi Wagmare by Dr. B.G. Wagmare sir. Dr. Rajendra Kamble sir, you are requested to get felicitated for Generous Philanthropist Award at the hands of Venerable Bhadanta Sangharatna Mankeji, who is the president of Panna, Japan. He is running.
Without Dr. Ravi's support, this conference wouldn't have reached to this extent. Give a big round of applause to him. Bahocon 2023 philanthropist. I would like to request Dr. Rajendra Kamble sir. He is always generous for Baho wherever, whenever. So he is a Baho's generous philanthropist. Rajendra Kamble sir is not seen here? Okay. Okay.
Next is women's category. The most intelligent doctor, Dr. Manisha Bhavatkar, Outstanding Achievers Award at the hands of the teacher of teachers, Dr. Bal Wagmare sir. Dr. Manisha, please come. Followed by another award winner, marathon running winner, the most Mr. Fit, Dr. Anand Gajbhe sir. You are requested to come on the stage and accept your award. What is the secret of fitness? I would like to request a staunch supporter, Mr. Arvinda Khaparde, and he will be felicitated by Bhadanta Sangharatna Mankeji. Yeah. Another felicitation of Dr. Krishna Kumar Dhemre sir is an encouraging pillar, and behind every successful man there is a hand of woman, but here there is a reversal of the shunt. Dr. Krishna Kumar Dhemre sir, the most fit person of Baho, he just crossed 70. Last year you might have enjoyed the big party given by Dhemre family. Yes, the most humble, most polite, and he is always working.
I now request all our MOCs to come one by one on the dais for felicitation. Dr. Rinkal Fusate, Dr. Preeti Dhoke, Dr. Nayan Dupare, Dr. Mukesh Wagmare, Dr. Rakesh Dhoke, Dr. Deepa Khobragade, Dr. Rajratna Ramteke, Dr. Neha Golghate, I request our chief guest to felicitate our MOCs. Dr. Ashish Bhavatkar, Dr. Nisha Meshram, Dr. Ketki Ramteke, Dr. Pritam Khairkar, Dr. Samiksha Moon, Dr. Harshanand Popalwar, Dr. Bobby Salame, Dr. Raj Ghotekar. I now request Atlas Biosciences Private Limited officiating sales managers to come on the dais and declare Mr. Rajesh and Mrs. Shraddha and declare 5 lucky winners. All MOCs, please collect your mementos. आप दे दीजिएगा मुझे.
So good evening all. Now there are
5
high
lucky
dose of a
winners.
lot of academic sessions. So we are from Atlas Biosciences Private Limited. I am Rajesh and Shri Shraddha. So yesterday I hope everybody must be knowing we have declared one lucky draw contest where 5 premium gifts were supposed to give to the lucky winners. I hope everybody must have dropped their visiting cards or they might have written their name number in our this lucky draw box. So I request President Dr. Trishala Demre ma'am and Khobragade sir to please come and please announce the lucky draw, 5 lucky draw winners. काटते सर. अरे सर आपका आएगा ना, हम देते ना सर आपको. अरे मैडम. So please.
Is this the first or the fifth one?
No, all gifts are same. Just you have to announce the name.
बरोबर नाही आहे.
Yeah, please.
The first one also gets the same and the last one also gets the same. So it goes to just any guesses? No? सर मुझे मिलता तो फिर मैं थोड़ा धीरे से बोलती. It goes to none other than the NIMS Hospital Director, Dr. Praveen Salame.
It may be either Salame sir, but the gift will be useful to Bobby ma'am. Yeah, please, second. Please.
सेकंड लकी विनर अभी डिक्लेयर होने वाले हैं.
अरे बाप रे. What is this? ये तो लॉटरी खुल गई सबकी. The second winner, or you can see the from the down line, it's a fourth winner. But the prices are same. So it goes to whom? The treasurer who is getting so many gifts. Treasurer, none other than Dr. Prafulla Sakre sir. क्या बात है सर, बहुत गिफ्ट्स ले जानी पड़ेगी आज तो.
सर प्लीज आप दोनों हैंडल कीजिए, थोड़ा फोटो भी आइए.
मैडम पैसे के पास ही पैसा जाता है.
पैसे के पास ही पैसा जाता है. शेक शेक शेक.
चेक करो मैडम.
हाँ शेक. ओ हाँ, इसमें नाम ही नहीं है. ये है. ओ
ये डॉक्टर त्रिशला ढेमरे मैडम का नाम निकला है.
वो निकालो.
चलो कांग्रेस लक ऑलवेज फेवर द ब्रेव. नहीं
या
एवरीथिंग इज फेयर इन लव एंड वार बोलते हैं, बराबर है.
There are must be more than 50-60 cards. They must be there. Yeah, please.
क्या मैडम.
बस दो है.
डॉक्टर प्रवीण नितनवरे. क्या बात. कॉन्ग्रेचुलेशंस.
क्लास भी निकाल लो.
तुम्हीच काढा. आप ही निकालो. आप ही निकालो. RL. Dr. RL Mande Buche, he is from Umred. He was civil surgeon. तो दूसरा नेक्स्ट.
What public says? Next is not there.
प्रशांत सहारे is also not there. डॉक्टर क्रिस्टाबेल गोम्स. कल से मैं ढूंढ रहा हूँ इनको, कल मिल नहीं रहा मुझे ये.
सर मैं अभी निकालूंगी. अभी देखते हो तो
अवेलेबल है, देख लो मैडम.
लेक्चर में नाम था उनका, बट पेपर.
ऑडियंस में बिल्कुल मौजूद है सुबह 9 बजे से लेकर शाम के 7:30 बजे तक. उल्टी सीधी पकड़ियां मैंने सब जानते हैं.
क्या बात है. मेरा नाम निकाले.
अरे वाह.
ओह सरप्राइज. थैंक यू वेरी मच. थैंक यू. चलो थैंक यू.
मैं आपको देना चाहूँगा.
थैंक यू.
Join me.
क्या बात है. थैंक यू.
Congratulations. Congratulations. चलो ठीक है मैडम के लिए.
ठीक है, दे दो मैडम को, दे दो मैडम, वहाँ पड़ी मैडम बसल्या तिकडे. चला नेक्स्ट.
फेलिसिटेशन आपका. हां, गेस्ट तुमच्या हाताने गेस्ट ऑफ ऑनरचा.
I would like to request Trishala Dembre madam to felicitate Badanta Sangaratna Mankeji, chief guest of today's function, by offering me the memento.
सबका है क्या? पिंपळगावकर नहीं है, दूसरे हटाओ. माहिती आहे तुमचे नाव आहेत, अनाऊन्स करा.
Dembre madam.
Now I request President Dr. Dembre Madam to felicitate respected Dr. B.J. Wagmare sir. Now I request our guest of honor, Dr. B.G. Wagmare sir, to say few words and bestow us with his blessings.
आदरणीय भंतेजी, या यशस्वी कॉन्फरन्सचे संघटक आणि त्यांचे सगळे सदस्य, आनंदमयी क्षण आहे हा, आणि अशा आनंदमयी क्षणाच्या आठवणीसाठी मातृभाषेशिवाय दुसरी कोणती भाषा आहे असं मला वाटत नाही. अशा वेळेला सगळ्या गोष्टी छान छान झाल्या असंच सांगण्याची प्रथा आहे, आणि खरोखर छान झाल्यात. कॉन्फरन्स घ्यायची ही आयडिया, ज्याला आपण कन्सेप्शन म्हणू, 2 महिन्यापूर्वी आली, आणि 2 महिन्यात सगळ्या गोष्टी योग्य प्रकारे प्लॅन करण्यात आल्या, ऑर्गनाईज करण्यात आल्या, आणि त्या एक्झिक्यूट करण्यात आल्यात. तुम्ही जेव्हा हे सगळं वातावरण बघतात, आजूबाजूला जे पॅनेल्स बघतात, ही सगळी आयडिया त्रिशला मॅडमच्या डोक्यातून आलेली, त्यांनी ती पूर्णपणे साकारली. काही लोकांना, काही स्पीकरला पर्टिक्युलरली, काही ऑडियन्सलासुद्धा थोडंसं हार्श वाटलं असेल, परंतु टाईम मॅनेजमेंट कसं करायचं हे डॉक्टर शंकर खोब्रागडेकडनं शिकण्यासारखं आहे. पण त्याचबरोबर मला हे नमूद करायचं आहे की कॉन्फरन्स म्हणजे काहीतरी घाईघाईनी आटपल्यासारखं असं व्हायला नको. लग्न असलं तर वरात ज्यांना काढायची असते ते बरोबर घोड्यावरूनच वरात काढणार, त्यांच्यासमोर जो काही बँडबाजा आहे तो बँडबाजा वाजणार, ज्याला नाचायचं आहे ते नाचणार, म्हणजे प्रत्येक क्षण ते एन्जॉय करणार. हे ऑडियन्स येतात तर ते काही फक्त त्या विषयाची माहिती करून घेण्यासाठी येत नाही, त्यांना तर ते घरी बसून व्हॉट्सअपवर म्हणा, गुगलवर म्हणा, किंवा टेक्स्टबुकवरूनही वाचता येतं. महत्त्वाचं काय आहे? इंटरॅक्शन विथ द स्पीकर. त्यामुळे काही जे आमचे डेलिगेट्स आलेत त्यांना असं वाटण्याची शक्यता आहे की मला अमुक स्पीकरशी बोलून माझ्या काही अडचणी जी आहेत त्या सोडून घ्यायच्या आहेत, किंवा त्याला जो आनंद मिळतो आहे, उदाहरणार्थ राऊत सरांचं जे ओरिजिनल वर्क आहे तर तो ह्याच्यानंतर प्राऊडपणे अभिमानाने सांगत फिरेल की मी हे जे रेफरन्सेस या टेक्स्टबुकमध्ये आलेले आहेत हे ज्यांचे आहेत ते राऊत सर यांच्याशी मी प्रत्यक्ष बोललेलो आहे, त्यांच्यासोबत माझा फोटो आहे. ह्या सगळ्या मेमरीजपासून त्याला वंचित व्हावं लागतं. तर ह्याच्यापासून आपल्याला काय धडा घ्यायचा आहे? ढिंगरे मॅडमनी ऑलरेडी सांगितलेलं आहे की त्यांनी एक पेटी ठेवलेली आहे आणि त्यांना काही सजेशन द्यायचे आहेत ते त्यांनी तेथे द्यावेत. परंतु हे सजेशन मी जे काही देतो ते काही गुपित नाही आहेत. आणि माझं सजेशन असं आहे की पुढच्या कॉन्फरन्सला भलेही टॉपिक तुम्ही 2 कमी ठेवा. म्हणजे आता प्रत्येक सेशनला आपण बघितलं की 4 टॉपिक होते. त्यांना आपण 15 मिनिटांचा वेळ दिला होता. त्याप्रमाणे स्पीकरनी 15 मिनिटाची तयारी केलेली होती आणि वेळेवर त्यांना आपण 12 मिनिट देतो, 10 मिनिट देतो. त्याची कुंजमना होते आणि त्यांना आपण घाईघाईने म्हणतो आणि त्याला काही बोलायच्या अगोदरच आपण चेअरमनला म्हणतो की जाऊन त्यांचं फेलिसिटेशन करा. तर हे कुठेतरी अब्रप्टली ब्रेक झाल्यासारखं वाटतं. मी कोणावर टीका करत नाही. जे ऑब्झर्वेशन आहे ते ऑब्झर्वेशन सांगतो आहे. त्यामुळे पुढच्या वेळेला त्यांनी म्हटलं आहे की वर्ड ऑफ विजडम, हे वर्ड ऑफ विजडम आहे. पुढच्या वेळेला ज्यांना कुणाला कॉन्फरन्स अरेंज करायची आहे त्यांनी टॉपिक कमी ठेवा, पण वेळ प्रत्येकाला बरोबर द्या आणि जो दिलेला आहे तो वेळेवर कमी करू नका. जास्तीत जास्त काय करता येईल तुम्ही त्याला ड्रॉप करा ना, की नाही आमच्याकडे वेळ आहे ड्रॉप करा. आपण बहुतेक दुसऱ्या कॉन्फरन्समध्ये काय करतो की बाकी उरलेले प्रश्न जे आहेत ते तुम्ही जेवणाच्या वेळेला विचारा. येथे जेवणाची वेळसुद्धा नक्की नाही आहे, त्याच्यामुळे तेथेसुद्धा काही बोलणं होतं की नाही त्याची काही कल्पना नाही आहे. हे एवढी जर एक ज्याला आपण म्हणू की जे मला जी कमी त्रुटी भासली, या त्रुटी व्यतिरिक्त या कॉन्फरन्समध्ये सगळ्याच गोष्टी छान झालेल्या आहेत. सगळ्यात जास्त एन्जॉय केलं असेल ते आपलं गेट टुगेदर. कारण कॉन्फरन्स ही जी आहे आपली हे एक फॅमिली फंक्शनसारखं झालं आहे. एकमेकांच्या गाठीभेटी झाल्यात. जे लोक आपल्याला कधी भेटत नाही, मलकावरून आलेले जीओ जाधव किती वर्षांनी मला भेटलेत, किती छान वाटलं मला. त्यांनी मला ओळखलं. आता लोक मला ओळखतात कारण माझे केस पांढरे झाले तरी माझा बेसिक चेहरा बहुतेक तोच आहे. परंतु ज्यावेळेला हे लोक, आता मॅडम म्हणाल्यात की मी विद्यार्थिनी आहे, त्यावेळेला मला आठवतं की त्यांचा जो ग्रुप होता यंग मुलींचा, तेव्हा आणि आताच्या याच्यामध्ये नेहमी पाहतो मी यांना ओळखू शकतो. परंतु ज्या मुलीनंतर लग्न झालं, त्यांना मुलं झालेत आणि वाढल्यात, त्या म्हणजे वयाने वाढल्यात, गुणवत्तेने वाढल्यात, तर त्यांना एकदम ओळखणं आणि प्लेस करणं की कुठे आहे नाही लक्षात येत. कदाचित वयामुळे झालेलं असेल. परंतु जेव्हा ते ओळखतात, परिचय देतात, आणि मला असं वाटतं की हा जो लांजेवार आहे या लांजेवाराला मी शिकवलेला आहे. जेव्हा आता तो मला सांगतो तर मला एक अवर्णनीय असा आनंद होतो. हे फक्त माझ्या बाबतीतच नाही, माझ्याबरोबर इतरही टीचर आहेत, त्यांनासुद्धा तोच आनंद आहे. हा आनंद तुम्ही मला अनुभवायला दिला, ही मला अत्यंत आनंदाची गोष्ट अशी वाटते. आणि मला असं वाटतं की मी टीचर झालो तर मला भरपूर जे काही मिळायला पाहिजे ती भरून पावलं. भलेही मला पैसे नसतील मिळाले, परंतु जो आत्मिक आनंद आहे तो आनंद मला मिळाला. हा सगळा तुम्ही मला मिळवून दिला. आणि तरुण व्हायचं असेल तर लोक काही औषधी सांगतात, अष्टाधांती सांगतात, भिडजी वगैरे सांगतात. परंतु मला वाटते तुम्हाला जर तरुण व्हायचं असेल तर तुम्ही तरुण माणसाच्या संगतीत राहा. शंकर खोब्रागडे, एव्हरग्रीन, त्रिशला मॅडम, त्यांच्याकडे वाटतच नाही की त्यांच्यावर वयाचा काही फरक झालेला आहे. तर मला ही संधी तुम्ही मला मिळवून दिलीत तरुण माणसाच्या संगतीत राहण्याची आणि मला आणखी तरुण होण्याची. याबद्दल मी आपले आभार मानतो आणि माझे 2 शब्द संपवतो. थँक्यू. जय भीम, जय भारत, जय बुद्ध.
Thank you very much, sir, for your words of wisdom. Now I request our chief guest, Bhadant Sangaratna Mankiji, to say few words and bless us.
अफसोस है कि मेरी मातृभाषा ही नहीं है. मैं चाहता हूँ मराठी में बोलूँ. मेरे चेहरे को जापान से आए या जापानी ये भावना सूट नहीं करती, लेकिन मेरी भाषा भी मराठी या हिंदी नहीं रही. इसलिए मैं शायद टूटे फूटे हिंदी मराठी जो मुझे ठीक से आती है वो भाषा इस्तेमाल करूँगा तो आप त्रास जाएंगे. इसलिए मैं थोड़ा अपना टूटी भाषा में आपसे संवाद करने की कोशिश करूँगा. 17वें दशक के पहले आपका क्षेत्र और मेरा मतलब हमारा जो क्षेत्र है वो एक ही इसमें गिना जाता था. मेडिकल और जो आध्यात्मिक, जो आप धर्म बोल सकते हैं, वो एक ही इसमें गिना जाता था. पर्वत को, नदी को, हवे को 17 सेंचुरी के पहले लोग हर इसमें देव भगवान अस्तित्व में है करके स्वीकार करते थे, लेकिन 17वीं सेंचुरी में जो गैलीलियो आए और उन्होंने जो वस्तु अंकीकरण कर सकते हैं उसी को ही महत्व दिया और बाकी को छोड़ दिया। अंकीकरण जो कर सकते हैं वो बहुत कम होता है, फिर भी गैलीलियो जैसे विद्वान ने एक रेशा खींच लिया, दिशा दे दिया, तो दुनिया उस गैलीलियो के अंगीकरण को मान्य देना चालू किए। फिर आधुनिक काल में डेकार्ट, जो आधुनिक काल में एक आध्यात्मिक वर्ड के महान व्यक्ति के रूप में गिना जाता है, उन्होंने भी साइंस और विज्ञान और सामग्री दुनिया को एक अलग पार्ट बना दिया और जो आध्यात्मिक बात है उसे अलग कर दिया। उसी कारण हमसे ये समझ सकते हैं कि 17वीं सेंचुरी के बाद में जो मेडिकल का पार्ट है और जो हम जिस एक धार्मिक के रूप में जी रहे हैं उसका पार्ट अलग हो गया। अदरवाइज उसके पहले आपका मेडिकल और हम जिस मार्ग में जी रहे धर्म, ये एक ही, तो दो सिक्के, एक सिक्के का दो पहलू भी नहीं बोलेंगे, वो एक ही था। वर्तमान में जो है वो अलग अलग हो गया। अलग अलग होने की आवश्यकता थी, कालानुसार अलग अलग होना भी चाहिए। लेकिन मैं आपको एक उदाहरण दूंगा बुद्ध धम्म के माध्यम से ही। आपने शायद ही एक व्यक्ति का नाम जो तथागत सम्यक संबुद्ध के जमाने में जीवित था, उनका नाम था जीवक। शायद आपने सुना होगा जीवक का नाम। ये बच्चा जन्मते ही एक कचरे के पेटी में डाल दिया गया था। इस राजे ने उसको देखा, बढ़ते बढ़ते उसकी कैपेबिलिटी देखकर अपने राजघराने में ही रखा। आगे जाकर वो एक कचरे के पेटी में फेंका गया बालक आगे जाकर महान डॉक्टर बना जीवक। मरे हालत में छपड़ा, इसलिए उसका लंबा आयु के होप के साथ में उसको जीवक ये नाम दिया गया। आप कभी राजगीर में गए होंगे तो गिरिधरकूट जाते वक्त रास्ते के दोनों साइड में 2500 वर्ष पहले, 2600 वर्ष पहले का डॉक्टर जीवक इनका दवाखाना था, उसका अवशेष अभी भी उपलब्ध है। यहाँ तक उपलब्ध है कि हमारी भावना से नहीं, भारत के पुरातत्व विभाग ने उसको एक्सेप्ट किया है कि वहाँ से जो निकले हुए औजार है उस औजार को, ये औजार के माध्यम से 2500 वर्ष पहले यहाँ ऑपरेशन किया होगा। किस तरह का ऑपरेशन था ये पता नहीं, छोटा होगा या बड़ा होगा, लेकिन पुरातत्व विभाग के कहने के कारण जीवक ने जो ऑपरेशन के लिए इस्तेमाल किया वो औजार भी आज उपस्थित हैं। आज मैं मेडिकल की तरफ नहीं जाऊंगा, एक उदाहरण के तौर पर जीवक का जीवन आपके सामने पेश कर रहा हूँ। जीवन एक महान डॉक्टर तो थे, लेकिन तथागत के शिष्य के रूप में भी जिए। जब तथागत सिद्धार्थ गौतम बुद्ध बीमार पड़ते थे या उनको औषध की ज़रूरत पड़ती थी, वैद्य की ज़रूरत पड़ती थी, तो जीवक हर वक्त उनके सामने हाजिर होते थे। एक तरफ का जीवक गुरु और तथागत ये शिष्य के रूप में। आज आप और मैं भी यकीन नहीं कर सकता हूँ कि सिद्धार्थ गौतम बुद्ध ये किसी के शिष्य के रूप में पेश आए होंगे, लेकिन ये हकीकत है कि जब शारीरिक बात आई तब तथागत जीवक के सामने एक शिष्य के रूप में जो जीवक कहे उसको ही एक्सेप्ट किया और अपने आयु 80 साल तक जिए। और जब कब आध्यात्मिक बात आती है, धार्मिक बात आती है, तब आज जिनका नाम दुनिया में चलता है वो जीवक तथागत सम्यक संबुद्ध सिद्धार्थ गौतम के सामने एक शिष्य के रूप में नमस्तक होकर ही गौतम बुद्ध का प्रवचन एक्सेप्ट करते थे। कहना ये है कि आज जो मेडिकल और धार्मिक ये भिन्न भिन्न रूट में चल रहा है, भिन्न भिन्न मार्ग से चल रहा है, ये आवश्यकता भी है, लेकिन कहीं ना कहीं हमने जीवक और सिद्धार्थ गौतम बुद्ध इनका जो रिलेशन था, शारीरिक बात आई तो सिद्धार्थ गौतम बुद्ध शिष्य, आध्यात्मिक बात आई तो जीवक शिष्य, ये दोनों का कॉम्बिनेशन बराबर था, इसलिए दोनों अपने जीवन को सुखमय जी पाए। इन्होंने शारीरिक के वक्त तथागत ने अपने बड़ापा को सामने किए रहे थे तो उनका शरीर सुधरना नहीं था। आध्यात्मिकता के वक्त जीवक ने अपने घमंडी को सामने लाए होते तो वो आध्यात्मिकता के माध्यम से बड़े नहीं हुए रहते। आदमी का जीवन जो होता है वो मार्फत शरीर से या मार्फत मन से नहीं होता, आध्यात्मिकता से नहीं होता है। ये दोनों का कंबाइन ठीक से हो तभी आदमी एक खुशमय, एक मंगलमय जीवन जीता है। तो कहीं ना कहीं आपका मेडिकल और धर्म ये 17वीं सेंचुरी के पहले जिस तरह का था उस तरह की अपेक्षा नहीं है, होना भी नहीं चाहिए। लेकिन आधुनिक रूप में जो मिलन हो सकता है, आधुनिक रूप में जो साथ में काम कर सकता है, वही हो, यही इच्छा है। और यही शब्द के साथ आज मेरे 2 शब्द समाप्त करता हूँ। नमो बुद्धाय।
धन्यवाद। थैंक यू सर। Now I request our chief guest to felicitate our dynamic president, Dr. Dhemre madam, with a token of appreciation.
हॅलो, आपण सगळ्यांनी 2 दिवस खूप मोठं सायंटिफिक सेशन बाहोकॉन बघितलं, विटनेस केलं आणि एन्जॉय केलं, खूप नॉलेज मिळवलं। हे सगळं करण्याच्या पाठीमागे, हे सगळं घडवून आणण्याच्या पाठीमागे आणि त्यांनी जे रात्रंदिवस मेहनत केली त्याचं आपण म्हणजे काही आपण त्यांचं परतफेड नाही करू शकत। आणि बाहो त्याच्याबद्दल खूप तुमचे ऋणी आहे मॅडम की तुम्ही हे इतकं मोठं छान सेशन आम्हाला म्हणजे दिलं, त्याच्यासाठी इट्स अ सरप्राईज, बट स्टील वी वॉन्ट टू फेलिसिटेट यू। आणि आमच्या सगळ्यांचे फिलिंग्स आहे की तुम्ही स्वतःसाठी तर काही कधी मागितलंच नाही, तुम्ही पे बॅक टू द सोसायटी म्हणूनच आम्हाला स्लोगन दिलं, पण आमचं पण काहीतरी एक हे बनतं की आम्ही तुमचं फेलिसिटेट करायला पाहिजे। त्यामुळे प्लीज ॲक्सेप्ट इट फ्रॉम बाहो।
Thank you very much. Chalo, thank you so much for, yes.
I have no words because I am feeling very small after receiving this. I never wanted this. Whatever I have done, it is just a payback because we have taken so much from Dr. Babasaheb Ambedkar. He has given us a lot and this is nothing. आपलंही काही समाजाला देणे आहे. This is what it made me again very small.
Last but not the least, now I request our Honorary Secretary, Bahocon, Dr. Shankar Khobragade sir, to present vote of thanks.
Thank you very much, Dr. Hitesh Borkar. Dignitaries on the dais, Venerable Bhadanta Sangaratna Mankeji, the teacher of teachers, Dr. B.G. Wagmare sir, the most eminent surgeon of international repute, head of the department, and he has created so many surgeons, Dr. B.S. Gedam sir, Dr. Manisha Dhanpalwar, Dr. Sanjeevani, and the force behind all this Bahocon 2023, the first lady president of Baho, Dr. Trishala Dhemre ma'am, and the important personalities in the August gathering, our vice chairperson, Dr. Suchit Bagde sir, the scientific committee chairperson, Dr. D.S. Raut sir, Dr. Ramteke sir, Dr. Praful Sakre sir, and the Raj Gotekar sir, and Sushant Meshram sir, Sunil Washimkar sir. There are no words to express my sincere thanks and gratitude in this concluding function. There is another public forum also after this 10-15 minutes. And the idea was conceived by our people, our organizing committee, that Baho is there, why we should not go for the Bahocon. And I pay my regards to the past president of Baho. They have given permission. Within 2 months, they have formed the committee, and we have been successful in organizing this conference in a very short duration time. The national speakers like Dr. Gotekar, Charan Lanjewar sir, and so many people, they have helped us, and the pharma person also, they have helped us for this conference. And Maharashtra Medical Council has granted 6 points for this. When Dr. Narayan Devgakar came here from the Nashik, he said, Dr. Khobragade, this is more than the national conference. And all the people, they have appreciated it. So it is this conference was not only for academic purpose. Lectures you can get at home, you can go for the Google, you can see on the YouTube, you can go for the tuitions. But this was for uniting our Ambedkarite doctors. The main purpose of this, there are so many super specialists in Nagpur. In last 3 days, we have been connected with so many people by heart. We were there, everybody was working. Dr. Hitesh was working in Viveka, Dr. Sushant is working. But this was the main motto of organizing. Babasaheb said, educate, agitate and organize. So main purpose was organization, not only organize, but implement it. And within last 3 days, we are working for conducting the scientific program, and there were 74 speakers. First day, we have conducted 36 lectures and organizing, getting finances from the companies. Every company wants their speaker. Every company wants their speaker. And that's why we have given 15 minutes time for each one. But there are some speakers, they want more, 2 minutes, 3 minutes, 4 minutes, so we were helpless. In national and international conference, you have to calculate your timing, you have to practice, and then you are allowed. So definitely this was our learning phase. We have done so many mistakes. We know who have done best, and the best lecture award also we have to declare, and I think we'll discuss in the organizing committee meeting, and everybody has witnessed this. And the lectures we have kept mixed. There are cardiology, medicine, surgery, ophthalmology, super specialty lectures, oncology lectures, and there are so many brilliant doctors. What we have found in the last 3 days, we have found that our doctors are not inferior to others, rather they are superior to others. So that's why this was the crux of this conference. And the junior force, they also work very hard. The resident doctors, the people who are doing PGs, they have also, we got 9 papers here. Clinical cases, first day 3 cases, followed by 4 cases today. And today we started at around 9:30 and we finished at around 6 o'clock. So this was a tremendous job, and we have tried to include hematology and all subjects. So this was our motto. And if we have done some mistakes, Wagmare sir, please forgive us. We are very small and we have not been successful to fulfill your expectation, because when students are there, they are bound to make mistakes. And you are there to correct our mistakes. So whenever next conference will be there, definitely we try to, that's why we have kept the suggestion box, and definitely. And first of all, I would like to give big a lot of thanks to this lady, Dr. Trishala Demere Madam. She is working so by heart. She has left her practice. Since last 2 months, she is not able to sleep properly also. Every time she is managing. And if you see the hoardings or this area, this was all surrounded by Babasaheb and literature. So definitely this vision is very, very important. And from the bottom of my heart, I would like to thank everybody who have helped us financially, physically, and mental support is also very, very important. A lot of thanks to Dr. Krishnakaran Demre. He has also supported us. And all the scientific committee chairpersons, musical committee, food committee, and all the committees who have helped us. So thank you so much. And if I forget the names of anybody, please forgive me. We are working for, not for us, but for Dr. Babasaheb Ambedkar. That is the only thing that he should not say that we have बड़े लिखे लोगों ने हमको धोखा दिया. ऐसा लोगों ने बोलना नहीं चाहिए. डॉक्टर के बारे में बहुत सारे लोग बोलते हैं ऐसा, ये डॉक्टर्स लोग कुछ काम नहीं करते, वो नहीं करते, वो नहीं करते. But in these last 3 days, everybody has worked very hard, and that was our unity. And long live Baho. Thank you very much. Jai Bhim, Namo Buddhaya.
खरं म्हटलं तर ऑफिशियल प्रोग्राम संपलेला आहे व्हॅलिडिटीचा. डॉक्टर शंकर खोब्रागडेंना एक बिग अप्लॉज द्या. आणि जे मी टाईम मॅनेजमेंटबद्दल सांगितलं पर्सनली घेऊ नका, कारण आम्हाला माहीत आहे की तुमच्यामुळे आम्हाला फार चांगले चांगले स्पीकर्स मिळालेत.
Thank you, sir. Thank you, sir. Now I request all to stand up for our national anthem. Jai.
I would like to invite everybody for public forum. There is one program for the public also, and I would like to welcome the